Good afternoon, everyone. My name is Megan Collette. Thank you so much for joining us today. It is 12:03, so we're going to go ahead and get started this afternoon. We want to thank you for taking the time to spend the afternoon with us for our Introduction to Treating Patients with Buprenorphine webinar. We hope that you guys will be an interactive crowd. If you could just make sure you're muted unless you have a question during the presentations, that would be fantastic. Otherwise, we would love for you to use the chat function for questions or comments for our presenters today. I'm joined today with my colleagues, Ashley Bushner and Katrina Hernandez. And if you need us for anything, please don't hesitate to reach out to us either throughout the presentation this afternoon. So we're going to go ahead and get started. As you'll see on the screen is a QR code. If you'd like to go ahead and scan that, we will be sending PDF information in the chat throughout the afternoon. If for some reason you're having trouble with that, again, please feel free to message us directly and we'll see if we can't help resolve your issues. So we're going to get started today with just a brief overview of what the Michigan Opioid Collaborative is and does. The Michigan Opioid Collaborative is an interdisciplinary team supporting providers and community to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. MOC is a grant-funded program through Blue Cross Blue Shield and MDHHS. We offer free same-day consultation services to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case consultations and questions related to treatment and management of substance use disorders. MOC offers quarterly introduction to Bupe trainings, which we're here today, as well as webinars on a variety of other educational topics, such as addiction, stigma, and substance use topics. We also have a hepatologist on our team who offers Hep C treatment consultations within 48 hours. She facilitates a biweekly case consultation webinar to review cases with providers and has developed a 3-part webinar series on HCV treatment. In addition, we have created toolkits for all our providers to have more resources when treating patients with multiple SUDs, and you can find those located on our website. The Michigan Opioid Collaborative has behavioral health consultants around the state that are happy to facilitate trainings, answer questions, troubleshoot with technical assistance, and be an extra support for you and your organization and your community. Again, please take a look at our website. Click on our events tab for other webinars and roundtables and other information, and we hope to see you again soon at a Michigan Opioid Collaborative event. At the bottom there, you'll see the email for getting a hold of our admin if you would like to have any other questions to ask as well. Joining the MOC is super easy, and what we do again is for providers, the buprenorphine trainings and the clinical assistance with setup for each office, and we also provide the same-day consultations. The BHCs also really help to connect providers with their community, provide those community connections, and lead webinars and other trainings as well. It's as easy as 1, 2, 3 to join us here in MOC for those free patient consultations. We have updated our new provider sign up, which is actually all available online if you'd like to do it all online on our website. Or your local BHC can email you the information. You send it back to the BHC, and then when you need us, you get a hold of us, and we will connect you with one of our consulting providers. There are 6 regions around the state of Michigan. We have BHCs in those regions, as you'll see here. And so after the webinar today, your local BHC will reach out to you with more information and an opportunity to ask more questions. Here's our great staff of consulting physicians. And so these folks will be who connect with you during those free patient consultations set up through the BHC. And we hope you'll reach out to us in the future. The BHC, again, we're a grant-funded program, and we are a part of Michigan Medicine at U of M. That's that on the Michigan Opioid Collaborative. I would love to begin our session today just by introducing our wonderful consulting physicians. Our first consulting physician today will be Dr. Frank, and also joining us will be Dr. Morrow. Just a bit about Dr. Morrow as he's joining us today in just a few minutes. Dr. Morrow received his MD and a PhD in neuroscience from the University of Michigan, where he is now an associate professor of psychiatry. His laboratory research focuses on the neurobiology of motivated behavior, and since 2011 has provided medication management and other clinical care to patients through the University of Michigan Addiction Treatment Services, otherwise known as UMATS. And Dr. Morrow will join us very shortly. And in the meantime, Dr. Frank, I'm going to go ahead and turn it over to you for your introduction and to begin our presentation today.
Great. Wonderful to see everybody today. Nice to see a nice mix of people. I was scrolling through the chat. It's always fun to have kind of a multidisciplinary group, which we have today, which is wonderful. So I'm Chris Frank. I'm a mixture of a family medicine doctor and addiction medicine doctor at U of M. And there is Dr. Morrow as we speak. He's joined us right there. John, they just gave you a very nice introduction. And so I've kind of worked in addiction medicine in rural places in Washington State, in federally qualified health centers, but also on inpatient side here at Michigan Medicine. And now I do a lot of work with students at the University of Michigan who have substance use disorders. So great to be here today. I'm gonna jump right into the early part of our presentation. We'll kind of go back and forth a little bit. Feel free to write questions in the chat or interrupt. The more interactive it is, the more fun it is, to be honest, for us. So, you know, go for it. Don't hold back. And really, this is, you know, for you guys. So the more interactive it is, the better it will be. So I want to start with just the course outline. We're going to take a brief introduction to the opioid situation right now, including reviewing some of the recent epidemiology changes. Dr. Morrow is going to review neurobiology of addiction, the basics of buprenorphine, and some of the details around buprenorphine intake and initiation for patients that you might be seeing in your clinical settings. And then I'll be doing some of the end part around some of the common patient management questions that pop up, especially as you're starting with patients managing opioid use disorder, and also some of the associated issues that are really common around stigma and harm reduction that are still ongoing issues in lots of parts of the state. And then we'll finish with a section on pain management and buprenorphine, which is also kind of really important topic for lots of clinical settings where many patients fall in the kind of gray zone between complex pain and an opioid use disorder. So for us, we're very excited because many people in the addiction medicine field have felt that one of the most stigmatizing parts of opioid use disorder treatment was this requirement to have an X waiver or a special DEA to prescribe buprenorphine, even though all of you will know that you need no special anything to prescribe just garbage canfuls of oxycodone and hydrocodone and fentanyl patches and lollipops and all kinds of stuff. So it never really made much sense because buprenorphine is much safer than a lot of the other opioids that don't have special requirements. But this was kind of an ongoing stigmatization of patients with opioid use disorder that has gone back, you know, all the way, I was going to say the 1920s, but even before that. So now there's no one can say that they can't prescribe anymore. That's essentially the situation. Is anyone with a DEA can prescribe. There's also fewer limits in terms of what you can do and how you can do it. And so it really frees up a lot of additional people to provide evidence-based care for patients. some of you may have heard about some changes around the DEA licensure in general. And so like all of us who have DEAs will have to show that they've had 8 hours of relevant SUD training at some point. And so one-time requirement for people like Dr. Morrow and I, we're kind of waived from this because we're boarded in either addiction medicine or addiction psychiatry, but lots of people will still have this requirement. You might notice people in your community who are trying to meet this requirement, and you should let them know that these are good courses and ways to do that. So people will need 8 hours, but you'll no longer need a waiver. One of the other introductory things that we want to just get out of the way is that there have been some changes around buprenorphine prescribing that are specifically due to the COVID pandemic. And so you may want to just keep your eyes open for this because there's still some movement in the DEA proposals around what you can and can't do with telehealth. And almost certainly there's going to be a requirement for an in-person visit at some point early on in people's treatment. So we'll just jump right into the epidemiology, and then we'll get into the sort of the meat of the issue, which is really how to safely and effectively use buprenorphine. So I don't have to tell this crew, I would imagine, that overdose deaths of all kinds have increased quite dramatically from the early or late 1990s. And we're seeing mostly now a significant overdose death rate that's mostly due to illicit fentanyl that is in our drug supply. So I know a lot of you already know this, but like we rarely see real heroin anymore. I haven't seen it in a long time. So even when people say that they're using heroin or using something else, or maybe even using pressed pills that they think are oxycodone, lots of those are fentanyl. And that's, fentanyl is obviously a very strong opioid that doesn't have a large margin for safety. And it's caused this sort of continued uptick in overdose deaths. The one good message that we have is that in Michigan, for the first time in a while, we've seen this drop in overdose deaths, and I think all of us are hopeful that is going to continue. But who knows? The other thing that's important to say early on is that opioid overdoses are not distributed equally. I think to destigmatize the disease, we often talk about how, these things can affect anybody. This can happen in any family, any community, all that, which is all true. But it's also kind of washes over some of the sort of racial and regional disparities in who dies from opioid overdoses. And so in Michigan, provisional overdose deaths, death rate is highest in African-American groups than white. And, some states are different, but at least in Michigan, those are higher than our American Indian, Alaska Natives, although I worked in Washington State where, where our Alaska Native population had really high overdose death rates. So it's really regional, changes a lot. And so this is 2021, this is 2022. So you can see that that the rate for Black Michiganders has gone up, and so has white. So it's while going back a little bit, it went high. We're seeing this downtick now, and hopefully it will continue. So I'm going to stop right there, and I'm going to kick it over to Dr. Morrow, who's going to jump in with, I know his favorite topic because he is like an expert on the neurobiology of addiction, and gives whole talks just on that. So this is right up his alley. All right, here you go, John.
Okay, great. Thank you. I need to get the slides. Just 1 second here. Yeah, because I am.
Oh, no, while you were pulling that up, I was just gonna say,
Okay.
I was just at the American Society of Addiction Medicine meeting in DC, and the Michigan Opioid Collaborative was well represented. And the most fun part was that we had a lot of clinicians from the Upper Peninsula in Michigan who actually come to some of our, hey, there's Mike Cates representing Marquette area. That it's super fun. And actually it's a wonderful community of people who are really dedicated to taking care of patients with substance use disorders. So, jump on in, the water's fine.
Okay. So, let me share the right screen. Okay, there we go. You should see it now. All right, so at this point, we're just going to talk a little bit about the neurobiology of addiction. I'll try not to get too carried away because that's my favorite thing. Not advancing. There it is. Okay. So the kind of basic idea is that drugs of abuse, not just opioids, but all substances and addictions, and even more generally, act on these reward pathways, specifically the mesolimbic and dopaminergic pathways in the brain. That's what gets taken over by addictive drugs. And just as a reminder, the reward pathway, the dopamine in that pathway comes from this VTA, the ventral tegmental area. Oh, I should do it. So there, VTA. It projects to a number of places, including the nucleus accumbens. That's going to drive a lot of the cravings and desires that people have, and the prefrontal cortex, which gives more of a conscious kind of control over what your next choice is going to be. So this is a normal kind of machinery of reward that gets hijacked in a way by drugs of abuse. So a little bit more on that. So natural rewards cause an increase in dopamine levels, particularly in the nucleus accumbens. And so these are graphs of that kind of directly measured in animals, where you see dopamine levels in the nucleus accumbens, and then once they get a reward, in this case is a food reward, it goes up. So you see that bump. And you see that with other types of rewards too. Normally, this dopamine release is triggered psychologically. You're getting some kind of pleasure, you're getting some kind of satisfaction about from something, and that causes a dopamine to be released. The dopamine doesn't cause the pleasure, it's the other way around usually. So the dopamine will cause the subject to want to repeat that experience. Whatever experience you just had, you want to do that again. That's what dopamine does. And this is an important mechanism for survival, right? This is how you stay alive. It's how you engage in things that are pleasurable, that are meeting your goals. That's why we have that system. The problem that comes in with drug use, I'll show you in the next slide here. So drugs also cause dopamine release, but drugs of abuse in general cause a much higher levels of dopamine release than natural rewards, which translates to a stronger desire or craving for the substance, and it's separate from the psychology. So the drugs themselves directly cause a dopamine release, regardless of whether you are experiencing pleasure or you met some kind of goal or whatever it is. None of that matters. If you took the drug, you're going to want to take the drug again. Subconscious, you'll come up with some conscious reason for why that's true, but the real reason is this: it's just directly releasing dopamine in your brain. And that's what leads to these pathological situations where people are using a substance even though it may not really make sense for them to do that in that situation. And this can come, this illustrates how this can come into play. You get tolerant to the effects of substances. Certainly in the case of opioids, but really all substance abuse, this is the case. And so this graph, it's kind of made up data, but this graph kind of illustrates that process where you take the drug and you get this increase in hedonic feeling. This pleasurable feeling goes up, euphoric, and then the drug wears off and that comes back down. With repeated use, you get tolerant to that pleasurable effect. So you get less and less pleasure out of the same amount of drug. And the lows get lower and lower because of that tolerance. So you're actually driven into a withdrawal state where you're depressed or other kind of things. And then you get to the point where you're using the drug really just to feel normal again. You're not really getting pleasure out of it. And so I'll get people in later stages of addiction say, I don't understand why do I keep doing this? It's not even fun anymore. It's because you're tolerant to the pleasurable effects, but you're not tolerant to the cravings for the drug. So when you stop the drug, you can expect this withdrawal state to happen. That's just a physiological response to ongoing drug use. And that's a physical dependence, a physiological adaptation to exposure to this substance. That's not the same as addiction. Addiction requires another piece to it. And so that other piece is really this increased craving, which is sensitized, kind of the opposite of tolerance. So, and that's illustrated here in these data. This is again dopamine measured directly in the nucleus accumbens after substance use. This is in an animal. You can't stick the probes in the brain of humans. So a lot of this is from animals. But we have evidence that the same thing happens in humans. So here we have two groups of animals that got amphetamine in this case. And you see the dopamine bump, and these are the ones in white get the amphetamine, and you get a big increase in dopamine that happens there. In black is another group of animals that got the same dose of amphetamine. But the difference between these groups is that group in black, that's their 6th time getting amphetamine. The white ones, it was their first time. But the black one, this is their 6th time getting amphetamine. You see the dopamine increase is stronger there. And if it was the 7th time, it would be even stronger. If it was the 10th, it would be stronger. The 20th time, it would get stronger. It sensitizes. That response grows and grows every time they use the drug. And that translates to a desire, a subconscious craving for the drug that actually increases the more they use. And so you put that together with the tolerance, where they're losing pleasure and they're increasing the desire for use. That's why you get somebody who really is not getting pleasure out of this drug anymore, but they have an intense desire to use the drug again. That's the pathology of addiction, kind of in a nutshell there. Okay, keep moving. So another aspect of the neurobiology of addiction comes from the prefrontal cortex interacting with the rest of the system. So I mentioned mostly the ventral tegmental area and the nucleus accumbens, but there's other parts to this. There's the amygdala, there's prefrontal cortex, as I said. One of the things that happens with substance use over time is you get increased cravings from these subcortical areas like the accumbens, and you get a decrease in inhibitory control that comes from the prefrontal cortex. That's your conscious self that's saying, hey, it's not appropriate to use right now. I have other things in my life that I want to do. We have lots of cravings. We have not lots of desires, I should say, all the time for things that may or may not be appropriate. But it's our conscious self, it's our prefrontal cortex that puts that in check. Well, substances and the process of addiction weakens that inhibitory control. It impairs the activity in the prefrontal cortex, and it weakens the connections between the prefrontal and the subcortical areas, so that you lose control over those cravings. This is another way of illustrating that. So normally, I keep pointing up. So normally in the non-addicted brain, you have a drive to do various things. In this case, we'll focus on substance use. So the substances are salient, and they'll produce a drive to use substances. That's influenced by your memories and your experience with the drug. But normally you have this control center. You have your conscious self, the front of your brain, that can override that drive with a stop signal. In the case of addiction, you have that same drive. It's actually increased because of that sensitization that happens. And your control system is not effective at intervening there. It's like the brakes have been cut. You've revved up the engine and you cut the brakes. The end result is you're going to go. You're going to use that drug. And so that's kind of the neurobiology that you're up against with addiction. I could say more, but I'll just leave it. So we have, there's multiple factors that can influence the development of an addiction or a substance use disorder. Not everybody who's exposed to substances develop a substance use disorder. In fact, the overwhelming majority of people don't. I mean, if you think about who is exposed, who just takes drugs that are potentially addictive, it's basically everybody. I think in this country, it's over 90% of people have tried alcohol at some point. But it's a fraction of that. It's a significant fraction, but it's a fraction of that actually develop an addiction to alcohol. And so some of the things that influence that are biology. There's certainly a genetic component to it. Addiction definitely runs in families. And there's also environmental factors. How you were raised, where you were raised, how much stress, that's a big factor, how much trauma or things that you may have experienced as a child. Who's around you? Who are your friends? What do they do? Are they using? These are big influences over whether you develop a substance use disorder. And then there's the actual use of substances. Some of that is just availability of the substance. You have to actually use it in order to develop the disorder. And that affects, all of these things together affect your brain mechanisms that can then lead to the substance use. The use itself will change your brain in some of the ways we've been talking about that results in a substance use disorder. So multiple things. Research suggests that it's about 50-50, genetics versus environment in terms of influence over vulnerability. It depends a little bit on the drug, but it's definitely both are involved there. Okay, so I think, actually I went through that a little quicker than I thought. So any questions about this neurobiology? If not, we can move to the next section. I think that has a lot more slides, so I'll probably have to move through it kind of quickly anyway. There we go. Okay. All right, so buprenorphine and naltrexone. So we'll start talking about these. Start off again with the basic pharmacology here. And so naltrexone, first of all, is an antagonist of the opioid, the mu opioid receptor. So that means when someone takes naltrexone, that's going to bind to those mu opioid receptors and block all activity at that receptor. So no matter how much naltrexone you take, it's going to have the same effect. It's just going to block activity at that receptor. As opposed to full agonists like heroin or methadone, that's just the opposite of that. Those bind to the receptor and they activate that receptor. So you get more activity at the mu opioid receptor when those drugs are bound. And the more, the higher dose you get, the more activity you'll get at that receptor. Buprenorphine is a partial agonist. So that means that the more buprenorphine you take, it's going to bind to that receptor. It's going to cause activity at that receptor. It will activate that receptor. But the maximum activity it can produce at that receptor is about half of what the receptor can do. So it only partially activates it. That means no matter how much buprenorphine you take, you'll only get about 50% activity at those mu opioid receptors. You could occupy every single receptor in your entire body with buprenorphine. It still is not going to get full activation. It'll be half activation of those receptors. Okay? So that's the biggest thing to understand about buprenorphine in terms of pharmacology. So yeah, I said buprenorphine and naltrexone. So we'll start with buprenorphine. So buprenorphine is it's an analog of thebaine, semi-synthetic analog, which means it's an opioid. That's what's different from an opiate is a naturally occurring opioid. And if it's synthetic, then we call it, we use the broader term of opioid. So if you just say opioid, you're not going to go wrong. So buprenorphine was approved in 2002 as a Schedule III drug. So that means you can prescribe that like other controlled substances. You can prescribe it with up to 5 refills. So a person can take it home, up to 5 refills. It's excluded mainly in the biliary tract, but you also get small amounts in the urine. And so when we do urine drug tests, it's detectable there because of those small amounts that are coming through in the urine. You'll mostly people take buprenorphine sublingually, which is going to bypass that first pass metabolism, and you'll get bioavailability around 30% with sublingual administration. And so buprenorphine has, it acts, I think we have a slide, but it acts kind of slowly. So its effects are spread out over time. That lessens the addiction risk because the addiction, you really have to tie the use of the substance to the brain effects, to the dopamine release in order for it to produce a really strong addiction effect. Buprenorphine spreads that out so that the two are not connected as much. And so you get less addictive potential there. And you're also not going to get the same sort of, because it's a partial agonist. So you're not going to activate those receptors all the way. There's some antagonist effects at the kappa opioid receptor as well as buprenorphine, which also reduces the risk of respiratory depression. So that's why it's much safer than just a full opioid agonist like oxycodone or like morphine or something. There's just not the same overdose risk with buprenorphine as there is with those. Okay. So receptor affinity here. Another important aspect of the pharmacology. So buprenorphine is a very high affinity for the mu opioid receptor, higher than basically any other opioid that the person is going to encounter. So that means if they take a full agonist, like heroin or even fentanyl, buprenorphine is going to displace that from the mu opioid receptor. It's going to knock it right off of the mu opioid receptor. And so you're going to get that partial agonism, and it's going to block all these full agonist effects that the person might put on top of there. That's one of the reasons it's very effective. And that's an important distinction. It binds tightly, the affinity is high. That doesn't mean it's going to activate it more. It's a partial agonist that binds very tightly there. Okay. Questions about that? Sometimes that can be confusing, but no, clear enough? Okay. All right, so if you take off an opioid from someone who's been on opioids for quite some time, you can expect opioid withdrawal. It's a very predictable result from stopping opioids. And that can be mild to severe. Some of the symptoms are listed here. This is taken from the clinical opiate, should be opioid really, withdrawal scale, the COWS. That's available online, so you can use that in your practice. And so if you take opioids for a sufficient amount of time, so example, if you take the equivalent of 20 to 30 milligrams of morphine for 2 weeks, that's enough time for somebody to develop a physical dependence on opioids. Just 2 weeks, and they're physically dependent on it. Very predictable. So that's what you can expect in opioid withdrawal. Very uncomfortable to people, certainly drives people to use more. It's not, unless they have an underlying medical condition, it's not going to kill them, but it's extremely uncomfortable for people. One thing you want to try to avoid with when you're starting on buprenorphine is precipitated withdrawal, acute withdrawal that happens all at once because somebody took buprenorphine. This is how that happens. If they have a full opioid agonist on board, heroin, methadone, oxycodone, and they take buprenorphine, that's going to displace all of those from the receptors and immediately bring down those receptors to 50% activation of what they were. So they have a lot of withdrawal all at once, precipitated withdrawal. That's what you want to avoid when you're starting somebody. That's why we want people to taper off of their other opioids, or you can start slowly with the buprenorphine so that you don't get this big withdrawal effect. Okay. Now, a little bit on the combination product. Buprenorphine is often combined with naloxone. That's Suboxone or Zubsolv. They have this combination of buprenorphine plus naloxone in it. The naloxone was added in there because the thought was that would reduce diversion because of the way those two, the differences in how they're absorbed. So if you take this product sublingually, so you put it under the tongue, buprenorphine is going to absorb pretty readily, as we said, that way. Naloxone, not as much. It's not zero, but not as much that way. And so the effect that the person is going to get is essentially just the buprenorphine. If they swallow it, neither one of them are really active if you swallow. So if you swallow buprenorphine, you're basically wasting the drugs. You got to put it under your tongue and let it sit. If you inject it or use it intranasally, if you sniff it, buprenorphine will absorb quite readily that way, but naloxone will also absorb pretty readily that way. And that will delay the effect of the buprenorphine. Naloxone will block that for not forever, but for about 20 minutes or so. You block that rush that people can get from an IV injection. So that reduces the chances that they're going to do that. And these products are not time release. So if you get a tablet or a film, you can split those. People will commonly do that in an outpatient setting. There's some hospital settings that don't allow that to happen, but in an outpatient setting, very common for people to take this strip and just cut it in half, cut the tablets to get the dose that they're looking for. So so it's important to note that there are different formulations of buprenorphine. And they have different they have different bioavailability. So the effective dose is different based on the product that you're using. So this buprenorphine naloxone combination, you have the generic, you have Buprenorphine, Suboxone, Zubsolv. It's listed there. You have different doses that are going to be equivalent based on the product. So just keep that in mind, that 16 milligrams of Suboxone is not the same as 16 milligrams of Zubsolv. You got to do the conversion there. And there's also there's an implant available now. There's Sublocade, which is an injection. Actually, I think we have a slide on that, so we'll talk about that in a second. There's different formulations available. Yeah, and this is the same. You'll have these slides, so you can see how to convert these based on the dose that the person is taking. We don't need to go too much into that. So yeah, here. So this is the Sublocade. This is an extended release formulation. It's given subcutaneous injection, and the idea is that this is for people so that they don't have to take the medication every day. If for whatever reason they want to take it, it's better for them to take it as a monthly shot, then this is available for them. It's not covered by every insurance, and it's pretty expensive if you're paid out of pocket there. But Medicaid covers it, so this is going to be a good option for a lot of people. This is particularly useful for, like I said, people who don't want to take something every day, or if it's just not feasible for them to do, like say you have someone who's homeless or something like that, it's going to be hard for them to keep track of medications like that. You can give them an injection and they're covered for a month with this. So that's a good option for a lot of people. Okay. So adverse effects of buprenorphine. This is going to be similar with any other opioid. These are class effects. Any opioid you take is going to have these sorts of side effects that are listed here. Couple of things to point out that people don't think about very much. One is central sleep apnea. It's on there somewhere. Yeah. So central sleep apnea. There's a lot that's not understood about it, but the prevalence might be as high as 25% with full opioid agonists. It's probably less with buprenorphine, but we're not sure about that. But that requires specialized treatment. A regular CPAP isn't going to work for somebody with central sleep apnea because the brain is actually not driving them to take a breath. Bone health can deteriorate over time due to decreased osteoclast activity. There's no data to guide recommendations on screening for this, but that's something to keep in mind with people on chronic opioids. And then secondary hypogonadism can also happen, especially in women. That's an important thing that needs more study, but that can happen as well. But notably, respiratory depression. That's why people die of overdose with opioids. It's their drive to breathe is reduced because of activity at that mu opioid receptor. That does not happen with buprenorphine because it's only a partial agonist. So no matter how much buprenorphine you take, you're not going to get a level of respiratory depression that will result in an overdose death. It's possible to overdose on buprenorphine if you combine it with benzodiazepines, potentially alcohol, some other kind of sedative that also lowers their drive to breathe. But buprenorphine alone, it's just not going to happen. It won't cause somebody to die of an overdose. Okay. So some of the goals of using medications for opioid use disorder, not just buprenorphine, but other interventions as well. The goals are preventing overdose and death, reducing cravings and withdrawal symptoms, blocking the euphoric effects of other opioids. That can certainly be a treatment goal. Improving your rates of engagement and treatment. Certainly people have better, they're retained longer in treatment if they're given medications to help with their disorders. Interrupt that cycle of seeking, using, recovering from drug use, and restoring the reward pathway to its normal state, at least to the extent that is possible with an addiction. These are things that medications for opioid use disorders can do. So important to keep what are the goals of treatment in mind when you're prescribing these. So how effective is buprenorphine and other treatments at reaching these goals? So there's a lot of goals, as I said, for treatment of substance use disorders. One of the biggest ones, this is the reason that we're so interested in treatment of opioids, that they're less common than alcohol, less common than marijuana. But we're so focused on it because of that overdose risk, because of the death, just direct death that you can get from using opioids. And if we look at that outcome measure, outpatient counseling has no effect on overdose deaths with opioids. Intensive behavioral health interventions, the intensive IOPs, the group therapies, no effect on overdose deaths. Inpatient treatment, detoxification, residential treatment, 90 days, whatever it is, no effect on overdose deaths. Buprenorphine, methadone will reduce overdose deaths by about 50%, a large effect on that particular outcome. And naltrexone, that's another one we'll talk about in a minute. Effective in a lot of ways, but it does not have an effect on overdose deaths. So if that's an outcome that you're looking for, and clearly that's an important one, these are good medications to use for that. Let's just go to the next slide here. This is another measure of how effective buprenorphine is. This is the number needed to treat, if people are familiar with that. So number needed to treat is how many patients would you have to give this drug to get an improvement in the outcome, to actually reduce your deaths by 1 or whatever your outcome is. So for a lot of drugs, certainly for chronic disorders, like as addiction is. So for statins, for antihypertensives, these are things that are prescribed very commonly. Number needed to treat for those is like 100 patients before you actually get an improvement in one of them. With naltrexone, if you're looking at abstinence, number needed to treat is 20, much more effective in that regard. Buprenorphine, number needed to treat is 2. Find me a medication that has a better effect size than that. It is extremely effective intervention for opioid use disorder. That doesn't mean everybody's gonna be cured from this. That's certainly not the case. But 50% will have I mean, it will save their life. So very good intervention. It really should be offered to people who have, I mean, it's kind of amazing that we have people with a disorder that's this deadly and this common, and we have an intervention that's so effective for it. They should be offered that intervention. Okay. So here's some patient outcomes. So I've been talking about overdose deaths, but that like 50% improvement that you get in overdose deaths, that applies to basically all other outcomes from opioid use. Abstinence from illicit opioids, opioid cravings, talked about mortality, occupational stability, you know, keeping your job, staying out of prison, taking care of your kids, staying in treatment, all of those things improve dramatically on a sufficient dose of buprenorphine. And when I say sufficient dose, we're talking 16 to 24 milligrams of buprenorphine. That's what the evidence shows. A lot of people want to be on less than that, but the evidence that we have is for 16 to 24 milligrams. A lot of people are kind of underdosed with buprenorphine. But if you give people an adequate dose, I mean, you can expect improvement in almost all areas of their life, really, with that. Some more things that have been shown scientifically. So improved HIV, Hep C outcomes, retention and treatment, like I said. There's recent evidence showing that these interventions are cost effective, improved quality of life, reduce death, reduce substance use, reduce criminal justice involvement. So very, very effective interventions, buprenorphine. And methadone as well. You know, that's a full opioid agonist, but that has very similar outcomes, improvements in outcomes as well. It's a lot less convenient for patients to take. It's a big imposition on them to have to go into the clinic every day to get their witnessed dose of their medication. Just think about your own life. What if you had to do that? That would be a big problem. But you know, with buprenorphine, you can take it home and use it that way, and you get similar just really substantial improvements clinically. Okay, so that's buprenorphine. And as we said, if you have questions about this, let me know. You can interrupt. That's totally fine. But if not, we will go on to naltrexone. So naltrexone, as opposed to buprenorphine, it's a different approach pharmacologically to opioid use disorder, because naltrexone is a mu opioid receptor antagonist that will not activate the receptor. It's not an opioid. It will block the effect of any opioid that the person takes, including their endogenous opioids. It's going to block all of that. It is not a controlled substance. It is FDA approved for the treatment of both opioid use disorder and alcohol use disorder, which buprenorphine is not. It's available orally and also as a monthly shot. It's an intramuscular shot. Important to note here that oral naltrexone is not effective for opioid use disorder. It has to be a shot if you're going to use that for opioid use disorder. And I think partly that's because naltrexone doesn't block cravings. It doesn't you know, directly treat cravings the way buprenorphine does. So if someone wants to use on naltrexone, they're just going to stop using naltrexone. That's less likely to happen if they have at least a monthly shot. At least they have a few days there before they can use, as opposed to the oral naltrexone is effective for 1 day. So it's not recommended in pregnant patients, basically because of the withdrawal risk. And if you're physically dependent on opioids, you have to be off of those for 7 to 10 days before taking it. Otherwise, you'll get this precipitated withdrawal again. And also important to remember that it results in reduced opioid tolerance. So patients have an increased risk of fatal overdose if they relapse after being on naltrexone. It wipes out the tolerance that they've built to opioids. That's also true with buprenorphine as well, but more so with naltrexone, because it's just a straight antagonist. Okay. So, yeah, as I said, the oral naltrexone only for alcohol use disorder, not for opioids. Only worked for a day or two. But the IM form, that monthly shot, you can use for opioid use disorders. Some people, you can take it every 21 days because it wears off a little early in them. That's perfectly fine to do. In fact, it's appropriate in a lot of cases. Medicaid will cover every 21 days. So that's a good thing to do for folks on naltrexone if they're these high metabolizers. Who would benefit from this? Anybody who doesn't want to take opioids, which is a lot of people. They maybe have a philosophical objection to taking opioids, and you're not going to be taking the medication. So you got to listen to the patient. If they don't want to take opioids, fine. Naltrexone is a good choice for them. If they don't want to take a medication every day, it's a good choice. Your withdrawal symptoms or opioid cravings. So a lot of people say, I don't want to go through withdrawal when I come off of buprenorphine. I don't know why you're coming off of buprenorphine if you have an opioid use disorder. But if that's their objection, that's not the case with naltrexone. They can stop naltrexone, they're not going to get any withdrawal from naltrexone. Liver enzymes, if those are elevated, then you want to at least think twice about prescribing naltrexone to folks. You want to talk to whoever's treating their liver and make sure, because naltrexone is also metabolized through the liver, so you want to be careful about that. Don't prescribe to pregnant or breastfeeding patients. There's too much of a risk for withdrawal there. Anybody who's getting opioid agonist therapy should not get it. So if they're taking opioid, if they're taking oxycodone chronically, if they're taking buprenorphine, if they're taking methadone, you can't give them naltrexone because it'll block that opioid and send them into withdrawal. And certainly if they have acute hepatitis, liver failure, you want to be careful about it. Adverse effects, usually people don't notice it at all when they're on naltrexone. It can cause headache, nausea, dizziness initially. That's more common with the oral formulation. But when you start somebody on naltrexone, I'll usually give them the oral form just to make sure that they tolerate it before giving them this monthly shot that they're going to have to suffer through if they actually get side effects from it. So just to make sure they can tolerate it, you might start out with oral. And certainly you can get site reactions, but keep in mind, reduce opioid tolerance. You want to tell the patient about that. If you go back to using opioids, you're not going to have the tolerance for it. If you use the same dose that you were using before, you'll probably die because you don't have the tolerance anymore. Okay. Yeah, this is more on that liver enzyme elevation. They've taken the black box warning away from naltrexone because it's not as dangerous in this regard as people used to think. It can cause if you use high doses of it, it can cause an elevation in liver enzymes. That will go back to baseline over time, but it is metabolized through the liver. If it's elevated, you want to recheck that. People say to check it, to monitor it every 3 to 6 months. There's no like official guideline for that. I don't think it's really necessary to check the liver enzymes on a regular basis with naltrexone. And even if the enzymes are elevated, if the cause is alcohol, you may want to just prescribe anyway. I would talk with their whoever's treating their liver disease, because that would be pretty significant at that level. But it's effective at reducing alcohol use, and it's a lot better than alcohol for the liver. So you might want to still go with naltrexone. Okay. So administration, you want to check their urine drug screens, do a pregnancy test if applicable. You just want to make sure that you know the situation that you're prescribing this in. You want to talk to them about precipitated withdrawal. Tell them about that risk so that they tell you about any opioids that they may have taken. They don't want it either, so just let them know that can happen. Give it in gluteal muscle. Let's see what else. You can get these site reactions. Just move it, or you can move it around and administer it slowly to avoid some of those reactions. Has to be refrigerated and come to room temperature before use. But once it's mixed up, you have to give it immediately so that it doesn't solidify. So you can hold this in the office for a patient and then take it out when they want it. A lot of times we will offer a bracelet or a tag or a wallet card to people in case of an emergency. This is a very strong opioid antagonist. So if somebody gets in an accident and they need analgesia, the people treating them need to know that they're on naltrexone so they can respond appropriately. So if they're unconscious or something, they may want to have some alert to that they're not just getting pumped full of oxycodone and people are wondering why it's not working. Okay, so here are some data on effectiveness of naltrexone. This is like a survival curve basically for their return to substance use, their relapse. Comparing buprenorphine here in blue to naltrexone, and you see that the relapse rates once they've initiated the treatment are actually pretty similar. But naltrexone is inferior to buprenorphine mainly because people can't tolerate starting it because you really have to be off of your opioids for a week before you can start naltrexone. That's just too hard for a lot of patients to do. They can't go through that much withdrawal because they really have to go through the entire withdrawal process before they can start naltrexone. So that's where people fall off of there. Okay, but here's the summary we have here. So pros and cons. Benefits of naltrexone: good for people who don't want opioid agonists for whatever reason. There's no risk of diversion. There's no street value certainly for naltrexone. You certainly can't overdose on naltrexone. It can be administered in any setting, long acting, and it treats both opioid use disorder and alcohol use disorder. So that can be a real advantage for some folks. Let's see, limitations: hard to start because of that withdrawal period that people have to go through. If people have severe liver disease, it may not be an option for them. You have that loss of tolerance, which again, that's also a problem with buprenorphine, but it's even more so with naltrexone, and that can lead to a fatal overdose when and if they relapse. And then pregnant women really should be getting methadone and buprenorphine, not naltrexone. But one thing that these medications have in common is that they stabilize the brain changes that have been happening with addiction, and to a certain extent, they can reverse some of those brain changes. not entirely. We don't have a cure for addiction, but it does facilitate healing. Being on these medications like this, you get a consistent message to the receptors. This is a big advantage with buprenorphine and methadone. I mean, naltrexone, but with an opioid use disorder, it's this irregular use of opioids. They get this big dose and then this crash and then going without it and then getting another dose, and these repeated spikes in opioids that leads to a lot of the brain pathology and the kind of negative effects of addiction. I mean, theoretically, you could use heroin as a treatment for opioid use disorder if they got regular doses of heroin, the same dose every day, the same time. In fact, I have a colleague in Germany who uses heroin to treat opioid use disorder like that. You can't do that here, but you get similar results if it's given in a controlled way like that. Because without that stabilization, without that regular pattern, people return to pretreatment use. And actually, that's important for when people take buprenorphine. They should be taking the same dose, the same way every day, not changing it based on their mood or how they feel. That's going to give you the best outcomes in terms of their stabilization. Okay, so I think that's it for that section. Any questions about this section so far? No? Okay. If not, then I will move to the next section on intake and initiation. So,
and thanks for all of the, oh, sorry. I was just going to say, thanks for all the questions in the chat. Yeah, keep them coming, because that's a good way for us to do it when things come up. We'll try to answer while the other person's presenting. So keep the good questions coming. Thanks.
Okay. Sorry. Next set. There. This. And yeah, you should see that. Okay.
John, before you get going, we have one more question in the chat there. If you and Dr. Frank can see that.
Let me see if I can find it.
I know it's hard to see them both. So we had the one question is, with long-term use of buprenorphine and success in stopping use of other opioids, is it recommended that individuals continue for life? If not, how does a person successfully wean down to zero? I'm asking because an individual has tried several times and can't get down lower than about 4 milligrams.
Yeah. So I think this will come up probably in one of your sections. But basically, the recommendations are that you continue buprenorphine as long as it's useful. There have been a number of studies on stopping buprenorphine in the setting of opioid use disorder, in terms of like stopping with a quick taper versus a longer taper. They didn't really find differences in outcomes when they do that. Basically, the slower you go, the better in terms of withdrawal risk. It's very common at the end of that taper. The very last bit is the hardest to come off, because there you can't really, you're going from 100% to 0% or to 50% of that. So that end of the taper is always the hardest part of it. But when I look at the research, when people taper off of buprenorphine, they've done this after 2 months, 3 months, 6 months, a year. The longest I've seen is 2 years. The outcomes for all of those were the same. The relapse rates were about 90% within a year of people coming off of buprenorphine, which is the same relapse rate that you have with opiate without treatment to begin with. So when I look at these data, it tells me that addiction is a chronic disorder. And when you stop treating it, you get relapses in it. I look at it like insulin dependent diabetes. Your blood sugar is under great control with insulin. What's going to happen when you stop taking insulin? Probably your blood sugar is going to get out of control again. I don't know, but probably that's what's going to happen. So, which is not to say that everybody, 90%, that's 10% of people do fine with that, but the odds are not in your favor. So that's what I tell people when they want to come off of, which is very common. People want to come off of buprenorphine. We're not trying to convince people to stay on to come off of it. It's really the other way around most of the time. So, but anyway, Dr. Frank will tell you more about that. So, okay, so buprenorphine intake and initiation. All right, so the first question when you are preparing to, thinking about whether I should prescribe buprenorphine, first question is, are you ready to prescribe buprenorphine in your clinic? And what I mean by that is, do you have the resources available to provide appropriate treatment in an appropriate setting? So do you have, does the person need medical care? Do they need psychiatric care? Are you able to provide that? Do you have someone to refer to who can provide that if you can? You want to think about that. Do you have on-call coverage? That's important for people on buprenorphine like this. I tell people if they need a refill, or they ran out of medication, and they can't get a hold of me, that's an emergency. I tell them to call our emergency line, and they can page me or give them a bridging script or something. But if they can't get their medication, they're going to go into withdrawal. They're probably going to relapse, and that's a high risk of death. So that's an emergency. So you want to think about that. And are there treatment programs available that will accept a referral to a setting with more intense levels of service if needed? Basically, if this person needs a higher level of care than I can provide, if they need intensive outpatient treatment, if they need residential treatment, do I know how to refer people for that treatment? So think about that first. And then you could start assessing patients for this intervention. So one thing, so just an overview here of the assessment process. You want to look for other substances that the person may be using: alcohol, other illicit substances, and tobacco. All of these are important to assess. It's very common for people to be using other substances. So you want to know if that's the case. Review their prescription drug monitoring program, the MAPS report. You want to see what other controlled substances maybe they be getting from other providers before you prescribe to them. And if, in fact, you're required to do that if you're giving controlled substances now, so you'll need to do that. Establish a diagnosis of an opioid use disorder and assess for other substance use disorder. So the number one was about use. This is about actually having a substance use disorder. Identify other comorbid conditions that the person maybe have, both psychiatric and medical conditions, and figure out, are they being addressed? How are they being addressed? The details of that. Evaluate their level of impairment, physical impairment, psychological, social functioning. And last but not least, determine whether they're, what's their level of interest in treatment. This isn't going to be your decision whether they get treatment. It's going to be a joint decision. So you have to understand where the patient is at. Okay, so first on that list is the substance use history. Here's a form that you can use that will facilitate this, make this a quicker process for you. Because you want to get, what of these substances has the person used? How old were they when they first used it? What's their pattern of use? How often are they using it? What route of administration are they using? All these things are important to know. And I ask about each of these classes separately. I don't just say, have you used other drugs? Because I've had too many patients where I ask that question and the answer is no. And then I say, well, what about cocaine? Oh, cocaine, yeah. Well, okay. So that's what I was talking about when I said other. So that's going to mean different things to different people. So you just want to go through those to be very explicit about what you're talking about. What's their treatment history? That's important. And even outside of treatment, if they've had any periods of sustained abstinence from substance use, you want to know about that. What was helpful? What actually led to that success at those times? If you were sober for 2 years, what happened? Let me know about that. Maybe we can do that again. And also the relapse. How did that end? How do we avoid that in the future? Consequences of use in different domains. So have they had medical consequences? Have they had complicated withdrawals? That's important to know. And then any other legal, social, occupational consequences of their use. Now, sometimes you have to draw that out of people too, because they may be in some level of denial about how much of an effect it's having on them. Had people say, my wife is going to divorce me if I don't come in here and talk to you, but this drug isn't causing any problems in my life. What about your marriage? Well, maybe, right? Your wife is going to divorce you. So you may want to draw some of those consequences out. Okay, so co-occurring mood disorders, another thing important to assess. It's about 30% of people with a psychiatric disorder will also have a co-occurring substance use disorder. And in converse, anybody with a substance use disorder, their lifetime prevalence of some other psychiatric disorder is over 50%. So most people with a substance use disorder are also going to have a psychiatric disorder. It's important to screen for that so that you know what you're looking at here. With mood symptoms or other psychiatric symptoms, you want to ask about the timeline, because substances can cause these types of symptoms themselves. So you want to try to distinguish. Sometimes it's impossible to know for sure, but you want to try to distinguish, is this a separate psychiatric disorder? Is all of this is consequences from substance use? So which came first? Were there any periods of extended abstinence, more than at least a month of abstinence? And if so, what were your symptoms like during that time? Were you depressed then? Were you anxious then? This is beyond the withdrawal phase, and then a family history can also be useful as well, because there's genetic components, again, to almost every psychiatric disorder as well. So that can be helpful in your diagnosis. If you have a lot of first-degree relatives with bipolar disorder, and it looks like you may have, it's certainly going to tip your suspicion in that direction that this person has a bipolar disorder. Okay. So, and another thing that certainly to assess is whether this person has an opioid use disorder. And to assess that, you use this is a summary of the DSM-5 criteria for an opioid use disorder. That's what it's for. So you just go through these criteria, ask about each one of them, and you can just tick them off, yes or no. Do they use larger amounts or longer periods than intended? Have they tried to cut down unsuccessfully? Are they spending a lot of time taking the drug or recovering from the drug? And so you see how many of those criteria they meet, and that gives you a score that you can use to determine how to describe how severe an opioid use disorder they may have. If all of these are no, they don't have an opioid use disorder, right? And if they have 2 or 3 of them, they may have a mild use disorder. It's certainly a range of severity here. And so that may give you an indication of how difficult this may be for this person to stop. Important to note that these last two, tolerance and withdrawal, those are criteria for the use disorder, but those can't be the only ones that they have because that's just physiological dependence on the drug. So if they get tolerance, if they get withdrawal, that doesn't necessarily mean they have an addiction to opioids. They have to meet, there's some other criteria that they also have to meet as well. Okay. So social history. These are all very important to keep in mind for your treatment plan. Do they have housing? Are they employed? Do they have family? You know, these things, this is going to determine in part what kind of treatment is going to be most appropriate for them. So you need to know the situation. You know, like for example, with buprenorphine, I talked about, you may want to prescribe Sublocade rather than an oral, like a sublingual form of buprenorphine. If somebody is homeless and it's not clear when they're going to have access to the medications, you cover them for a month that way. So I have other things listed here: social supports, education, legal issues. That's important to know about too. Religion, sexual orientation, and again, all of these things can influence your treatment plan. You know, if you're referring for peer support like AA or NA or something like that, how comfortable is this person going to be walking into a room full of straight white men, for example? You know, like, is there some other group that would be more appropriate? So, but you need to know a little bit about their background before you can even think about that in terms of your treatment. Okay. Very important to know about is, we talked about other substances, but in particular, if you're prescribing buprenorphine for opioid use, concurrent sedative hypnotics. And so that's alcohol, certainly, but especially benzodiazepines, barbiturates too, but they're certainly not as common as benzodiazepines. You need to know about that. And the reason is, as I mentioned, the one way you can overdose on buprenorphine is if you combine it with these other substances. So that puts them at higher risk if they're using, you know, alprazolam or lorazepam, some of these benzodiazepines as well. It's pretty common in people who use opioids, so you definitely want to screen for that so that you know. That is a relative contraindication to prescribing buprenorphine. And so if that's the case, certainly if they have a benzodiazepine use disorder, you may want to think about a higher level of care, some kind of medically supervised withdrawal. So if they're not overdosing on something that you prescribed along with their benzodiazepine. And alcohol, I'll just say alcohol is mentioned here. That is, it's more of a theoretical risk. There haven't been a lot of cases, I don't think, of people actually overdosing on a combination of alcohol and buprenorphine. I think because you really have to use massive amounts of alcohol to get respiratory depression from it. But if you do that, and theoretically, yeah, you could do that with more easily with buprenorphine on board. Another thing to keep in mind, though, if the choice is between using, getting a buprenorphine to treat their opioid use disorder along with this benzodiazepine that they're taking, versus, if you don't do that, what they're going to do is continue using full opioid agonists, fentanyl or heroin, along with their benzodiazepine, they're at lower risk if you give them buprenorphine. That's actually helping the patient if you give them buprenorphine. Sure, they're at risk of overdosing on buprenorphine, but you have lowered their overall risk of overdose and death by doing that. So it is a reasonable thing to document that, that thought process and go ahead and prescribe them buprenorphine as a harm reduction intervention. Always think about what's going to happen to the patient? Are they going to be better off or worse off given the intervention that I'm doing? Okay. So here, where are we in terms of time? I think we're okay, right? Yeah, we're okay. Okay. So induction and initiation. So this induction, it refers to the process of starting someone on buprenorphine. They have to be in mild to moderate withdrawal. That's because they need some mu opioid receptors that are not occupied by a full opioid agonist. That's so that you don't give them a precipitated withdrawal. Because if all of their receptors or a large number of their receptors are occupied by the full agonist, you replace it with a partial agonist with buprenorphine, that drops very rapidly the overall opioid activity, and they'll get precipitated withdrawal. So you want to make sure that they're in mild to moderate withdrawal. Sometimes patients may not get a lot of withdrawal symptoms if they're using prescription pills. Usually they'll get some though. And so you want to wait until they're in mild to moderate withdrawal. And then you titrate up your buprenorphine dose to whatever dose is needed to curb their cravings, minimize their withdrawal symptoms and side effects that they're getting from it. So that's the overall plan with starting buprenorphine. So before you start buprenorphine, you want to talk about, set some expectations for the treatment. It helps to have a written treatment agreement that lays out your expectations in terms of coming to appointments, bringing pills if you want to do pill counts, not sharing the drug. If they run out early or they get lost or stolen, how are you going to handle that? Have that kind of thing written out beforehand so that you're not facing these things without having talked about it before with the patient. You want to get consents and a start talking form. That's been in place for a while now, but that's a legal requirement. Anybody who's getting an opioid, any kind of opioid, you need to fill out this form saying that you talked about some of the dangers with opioids. Informed consent includes other FDA-approved treatment options, so naltrexone and other things, treatment without medications, and some of these other potential problems with opioid use. You don't necessarily need labs before your initiation, but it's helpful to have these other things. So CMP, hepatitis B and C, HIV, pregnancy test, all of those are good to have, as well as a urine drug screen. But important to remember, this should not delay their treatment. It's good information to have, but it's not a reason to not start somebody on buprenorphine if you can't get these labs for whatever reason right away. Drug screening, again, important part of treatment, but it's not always reliable. So it may not detect some of the things that the person has been using. There's ways to get around a drug screen. So talk to the patient about precipitated withdrawal. Tell them, if you have used opioids and we start this buprenorphine, you're going to get precipitated withdrawal and you're going to hate life. If they understand that, then they'll make sure that they're in withdrawal before taking the buprenorphine. So we used to do this in the office pretty much all the time, but the guidelines have changed now, and there's been more studies on at-home initiations of buprenorphine. And I can tell you, like, certainly during the pandemic, we've switched to basically all our inductions are at-home inductions at this point. Benefits to that, patients are just more comfortable doing those initiations at home. They don't need a driver. You don't need to coordinate scheduling. It's less of a burden on clinic resources as well. And it's really pretty safe to do. The only thing you have to worry about is that precipitated withdrawal, which again, if you explain it to people, then they're going to do it. They've used opioids for quite some time now, usually. So they're pretty familiar with the process of using opioids. They can manage buprenorphine if you give them instructions on how to do it. So almost everybody I've encountered is able to handle this at-home induction. So that's really our preferred way. Because it really can be a big barrier for people having to schedule and come in withdrawal, and at a specific time I'm going to be at this level of withdrawal, and that's when I'm going to take my buprenorphine. They have a little more flexibility if they can just do that at home when they're ready. So that's the observed versus unobserved. The different types of initiation you can do. The other different type here is, variation on this is you have the traditional initiation that I just talked about. There's also microdosing initiation and the high dose macrodosing initiation. I don't really do the macrodosing initiation, so I won't talk too much about that. I think that requires level of expertise and a little bit of adventurousness that I think is a little too much when you're first starting out with buprenorphine treatment. But we'll talk a little bit about the low dose initiation as well. So you'll have this in your materials, but this is a commentary that we recommend reading. This is about initiating buprenorphine, especially in the era of fentanyl, and how important this is, and just some strategies on how to do that effectively with patients. It's a good commentary to take note of. So here's the slide on microdosing. So as I said, a big barrier for people is getting through that withdrawal phase that you have to do, stopping your opioids and going into withdrawal before you can start your treatment. And some people just really cannot tolerate that. Even that one day of withdrawal, they can't seem to do that. So one way of avoiding that altogether is this microdosing schedule, where they actually don't stop taking their full opioid agonist until they're on a fair amount of buprenorphine already. The way you can accomplish that is by using very small doses of buprenorphine at first. So 1/4 milligram on the first day. That certainly is going to drop the opioid activity by 50% in some of their receptors, but it's not going to cause precipitated withdrawal because it's only a small portion of their receptors that are getting dropped like that. So if you do that on the first day and then you increase that by another 1/4 milligram, and then you go up gradually like this schedule shows, then you can kind of gradually replace their full opioid agonist with buprenorphine, and then you're fully on the buprenorphine at that point. The buprenorphine itself is going to block the opioids that they're taking on top of it, whatever it is, the oxycodone, the fentanyl, whatever it is going to block all of that. So by the time they're on a full dose of buprenorphine, they can stop using their fentanyl, their heroin, whatever it is, and they won't notice any difference because it's not doing anything anymore. It's already been blocked by the buprenorphine. So that's a way to kind of ease into the buprenorphine induction without this withdrawal phase for people who really just can't tolerate going through that withdrawal. So if people do get a precipitated withdrawal, there are ways to manage that. The way to do it's very uncomfortable, but as I said, it's, unless they're already kind of medically ill for some reason, just can't handle that kind of stress, it's not medically dangerous to people. So the way you can manage that, you can prescribe various medications to treat their withdrawal symptoms. So something like clonidine can treat that hyperadrenergic states of the blood pressure going up and down and these types of things. Clonidine can help with a lot of those types of core symptoms of withdrawal. For pain, you can give NSAIDs. Insomnia, benzodiazepines can certainly be useful. You can also use something like trazodone or something like that as well. I don't know if I would give benzodiazepines with opioid use disorder, but you know, there's things that you can use to treat the insomnia. Dicyclamine, the bentyl for abdominal cramps, and then for diarrhea, you can give loperamide for that. So those are ways you can help with the precipitated withdrawal. The other thing you can do is actually more straightforward, is just to give more buprenorphine and kind of push through. That's really the macrodosing schedule, is just to blast with buprenorphine. What they're getting is this withdrawal state, and if you just increase the buprenorphine enough, then that will start to treat the withdrawal. It won't completely take it away, but you can get pretty good control over it just increasing the dose rapidly. You've already kind of failed in avoiding the precipitated withdrawal entirely, so you may as well just kind of push through. And it's rare, if not never happens, that somebody who goes through a precipitated withdrawal this way is going to come back to reinitiate the buprenorphine. They're going to get scared away by that and probably not come back to see you. So if you can go ahead and just get them on the buprenorphine at that stage when they're in the office with you or whatever, that would, you'll have a better chance of retaining them in treatment if you can do that. Okay, but all that said, I've talked about this. If you're prescribing right, if the patient's following the instruction and you're prescribing it, there's no reason to see a precipitated withdrawal in folks. It's in fact, I'm trying to think of a time when I actually had somebody go through a precipitated withdrawal, and I can't think of one. So don't be afraid of prescribing because you might cause a precipitated withdrawal. That's not a reason to deny people care. Just go ahead with it. It's probably not going to happen, and even if it does, I mean, there's ways to manage it. It's not the end of the world if it does happen. So okay, okay. So patient instructions here. This is what you want to give to people who are going to do an at-home induction, or even if they're doing it in the office, you want to tell them what's going on. Yeah, so symptom burden. Yeah, okay, so this is talking about how long they need to be off of the opioids. It's really when they're in withdrawal, is whenever that is, that's the time to start the buprenorphine. And so that's going to vary depending on the opioid that they're taking because they have different pharmacokinetics. So prescription opioid pills, the short-acting ones anyway, you can abstain for 12 to 16 hours, and that's fine to start the initiation at that point because they would have basically worn off at that point. Heroin and fentanyl, it's more like 24 to 48 hours for that. Keep in mind that heroin is fentanyl at this point. You're not going to get somebody who's just using heroin. And in fact, most of the prescription opioid pills are fentanyl because it's masquerading as a pill or it's been pressed along with that pill. So whatever they think they're taking is probably fentanyl. And we have a slide on that, but with fentanyl is fat soluble more so than these other opioids, so it tends to stick around for a longer period of time. So even beyond that 48 hours, they still could be at risk for a precipitated withdrawal with fentanyl. So you really want to judge their symptoms. Are they in withdrawal right now? And for that, you can use these scales, the clinical opioid withdrawal scale or the self-administered, I think it is, the SOWS, the opioid withdrawal scale. So you can just add up their symptoms, you'll get a score, and then based on that score, you can initiate if it's high enough. Make sure that the person understands how to take buprenorphine. So if you're giving a sublingual, which usually is the case, their mouth needs to be kind of wet. They can't have a dry mouth taking it because it needs to absorb through the membrane. Don't smoke for at least a half hour before taking it because the smoking will dry up their mouth. And make sure they put it under the tongue and leave it there to absorb. They don't swallow it because that's not going to work. And then, yeah, again, tell them about I've said that enough times. Tell them about the precipitated withdrawal. You should sound like a broken record like me. If you are using opioids, you're going to get a precipitated withdrawal when we start this. So don't do that. Or tell me if you are, we'll come up with a strategy. Okay, so the first prescription, how much buprenorphine you're going to prescribe that first time depends on a lot of things. Prior auths are less of a problem now than they used to be with buprenorphine. You can usually get coverage from that from somewhere. You should co-prescribe naloxone. Naloxone is another opioid antagonist like naltrexone, but you can give that intranasally as a rescue medication for opioid overdose. Anybody with an opioid use disorder should be getting naloxone as a prescription and instructing them how to use it, but more importantly, instructing somebody who lives with them how to use it, right? Because they're not going to use it on themselves. So they should have that, and in case they overdose, they'll have a rescue. I would consider an initial prescription, 3 days to 7 days worth of the medication, enough to get them to their next appointment with you, which hopefully should be within that kind of time frame to assess how it's going. That's in an ideal world how much you're going to be prescribing somebody. But you also have to think about practically what is their copay on this medication. How much is it going to cost them? Do they have the resources to do that? For some people, it's just not reasonable, given their current situation, to have them go every few days and pay their copay every few days for this medication. They may need a longer prescription just because of their practical situation. Keep in mind, again, they're not going to overdose on buprenorphine. It's a lot safer than the opioids, whatever opioids they're taking is a lot safer than that. So giving them a longer prescription, okay, you know, maybe we have to do that. That's fine. So for dosing, you want to dose people adequately with an adequate dose of buprenorphine, especially at first. There's good evidence that getting people up to at least 16 milligrams is going to protect them against relapse. You'll get better retention in treatment with people on 16 milligrams. So I try to, sometimes I'm fighting with the patient to get them to go up to that to that level. If they're getting a lot of side effects on it, if they're getting sleepy, if they're getting constipated, all these types of things, maybe they don't need that much buprenorphine. But if they're not getting those side effects, they're tolerating the medication, get it up to a good dose, at least 16 milligrams or beyond that. Especially with fentanyl, it's not uncommon at all for people to need 20 milligrams, 24 milligrams of buprenorphine. That's fine. That's totally fine. What you don't want to do is give them less than they need. And then, so the official package insert recommends starting at 12 milligrams of buprenorphine. Like I say, usually that's not enough. I would tend to go with 16. So Medicaid, most insurances are going to cover a dose of 24 milligrams without prior authorization. If you need to go beyond 24 milligrams, they're going to be asking questions, and appropriately so. I mean, if you go beyond, once you get to 24 milligrams, basically every receptor in their body is already occupied with buprenorphine. So there's not much more that you're going to get from a higher dose of buprenorphine. It's safe, it's perfectly safe to do that, but it's just this kind of a waste of medication to do that. Okay, so instructions again. So these are things that we can give to the patients. The patient guide like this tells them how much to take, wait an hour, and then take some more. This is basically kind of self-titrating to see, first of all, whether they're going to get precipitated withdrawal from this dose, and then what dose is going to be adequate to control their withdrawal symptoms and reduce their cravings. We talked about a lot of this. Document your decisions for sure. Keep in mind with fentanyl, again, it's stored in the fat, so it may take longer for them to feel better with fentanyl than with other opioids. They can self-titrate when they start getting sedated or something like that. That's too much. They don't need that much buprenorphine, but up to that point, it's totally fine. So if the patient is not currently dependent on opioids, maybe they've already had withdrawal, maybe they're coming out of jail, maybe they're coming out of the hospital, and now they're starting opioids when they're starting treatment for opioid use disorder when they're not actually using opioids, then you don't have to worry about precipitated withdrawal. You still want to start at a relatively low dose just to make sure that they're going to tolerate this and avoid side effects. But you don't have to wait at all. You can just start, and they don't need to be in. They're not going to be in withdrawal, so you certainly don't need to wait for that. Just go ahead and start with the buprenorphine and get to a dose that they can tolerate. Again, they're experienced opioid users, so they can do a lot of this titration themselves. Okay. We kind of talked about precipitated withdrawal, haven't we? Let me see. So the last part there, if the person is just uncontrollably vomiting and things like that, you can send them to the ER for management. It's just supportive care that they'll be doing, but there's no reason to do all of that in your office. They may need to just go into the emergency room for that. Actually went through this already. Yeah, that's what I said here. This larger dose of buprenorphine you can use to treat precipitated withdrawal. And sorry, I'm just keeping track of the time here. We have to go through. So day 2, yeah. So whatever they took on the first, so on the second day after they've reached a dose that they've gotten, kind of comfortable with, they take whatever dose they took on the first day. They can split that up if they want. Most patients are gonna want to split pharmacologically. There's no reason to do that. You can take buprenorphine once a day; it's fine. But there's certain effects. Certainly with pain control, it's better to take it multiple times a day. And so a lot of patients, I'd say most of them, end up taking it multiple times a day. I would just have them stick to a schedule and do that every day. But if it's 3 times a day, once a day, it doesn't really matter. So take their total dose and then add on top of that, depending on what withdrawal symptoms and cravings they may be getting. Day 3 to 7, you're still titrating. You want to follow up within that time period and just ask them, how did it go? How much are they taking? What's their schedule? What's their withdrawal? Just monitor that and give them some advice based on what you're hearing. Okay, that's all. Okay, so we have a case. I'll try to go through this case kind of quickly so that we can break at the right time. So we have a case here that we can go through, Jenny. So Jenny is a 23-year-old social work student with heroin use. She is presenting comfortable, not yet in opioid withdrawal. Tells you she's been feeling anxious most of her life. Started smoking marijuana, using alcohol on the weekends in high school. In college, she got some oxycodone and noticed that in addition to pain control, her anxiety was lower. She felt normal. She felt peaceful. So then she started buying oxycodone from her friends, got up to 200 milligrams a day. A year ago, she did 28 days residential treatment, never followed up, and relapsed 6 weeks later. She's never been on medications for opioid use disorder. And because of costs and availability, she switched from oxycodone to snorting heroin, which is really fentanyl, 10 bags a day. Last use was 4 hours ago. So, key treatment considerations. Number 1, is she currently ready to start buprenorphine? In the interest of time, I would just say she is not. She just used 4 hours ago. She's not in withdrawal. She needs to be in withdrawal, and you would assess that using those scales that we talked about, right? The COWS, the SOWS, you would assess it that way. Is she a candidate for an unobserved home initiation? I would say yes, she's an excellent candidate for that. She's got some stability in her life, really. So she's got a home to go to. She's a graduate student. She can follow instructions. So you send her the instructions and have her do it at home. Perfectly fine to do. Most people are, really. So you explain that since she's physically dependent on opioids, she has to be in mild to moderate withdrawal to avoid the precipitated withdrawal. She understands that. You tell her to stop all her opioids for 16 hours at least, monitor her symptoms. After about 20 hours, she's experiencing piloerection, muscle aches, nausea, yawning, rhinorrhea, anxiety, insomnia. She hasn't used any opioids since she left the office. So is she ready for the initiation? Yes, all of those symptoms tell you now she's ready to start the initiation. Again, you would assess that with the scale, but she's going to reach criteria on the scale with all of that. So she starts the buprenorphine at 2 milligrams. So the question, how long until the initial effect? That's going to be about 30 minutes. And then the peak effect is going to be in 2 or 3 hours. So 45 minutes after her initial dose, she has no change in her withdrawal symptoms. So she takes the rest of the 8 milligram film. So what about additional day 1 doses. I would say continue to take additional doses as needed for withdrawal, up to 16 milligrams on that first day. And then day 2, she takes all 16 milligrams. That seems to be enough for her, so she stays on that dose for the rest of the days 1 through 5. She feels 80% better, but she's still having cramping in her calves. She has some anxiety, some insomnia. So what other history would you get? For this, I would just I would ask about kind of other potential causes of this. Does she have some kind of comorbid psychiatric disorder or something else that we need to be worried about? But probably in this situation, let's just try a higher dose. She's on 16 milligrams. The maximum is 24. Let's go up and see if any of these things get better. If it does, great. If not, well, now we have something else to deal with, right? But very common side effects, so may as well try to treat that with the buprenorphine.
We have 3 sections left, one on some common management questions, and that's important because a lot of those questions have already been raised in the chat today, and so we know that these are common. Sometimes they have easy answers, sometimes they don't, but they're really important to think about because sometimes they can be barriers for people to to provide treatment. Then the next 2 sections are around stigma and harm reduction and buprenorphine and pain management, which are also important. B. Bush says, "Are we ready?" I think we're ready. The outline for this section is we want to talk about follow-up. So once patients have started on buprenorphine, how we manage them going forward. Want to talk a little bit about urine toxicology, which is an important topic, and then some of the other supporting wraparound structures, the psychosocial support that support people in long-term recovery. And then there was a question earlier about discontinuation and tapering. We want to get to that. And then we want to talk about a few other things that we don't use a lot. We use the PDMP a lot, but we don't use pill counts very often. And we want to talk about return to use, which is, unfortunately a feature, not a bug, of substance use disorders. And then we have some cases to go through also. So we're asked often about frequency of follow-up, and the short answer is there is no answer. But that's actually really similar to pretty much all the other medical problems that we manage, right? There's really, beyond a few guidelines out there, there's not necessarily clear answers about the best way to see people in any setting, including well child visits for peds, whether it's health maintenance visits for adults, whether it's diabetes visits or whatever. One of the really common manuals that a lot of us use recommends, that stable people are seen every 2 to 4 weeks. I think, people who've done this for a while tend to flex up and down based on how people are doing. So when people are not doing well, the answer is usually to intensify care. That usually means seeing people more frequently. And then when people are doing really well, we space it out. Most people don't go past, 3 or 4 months with people, but, there are some people out there who've been on the same dose stable for, 5-6 years, and, don't need a lot of visits. And so we just want to make sure that people have the mindset that in general, when things aren't going well, you intensify care. When things are going well, you can space it out. Sometimes the human default is maybe if you're uncomfortable in a situation, you start spacing out. And usually it should be the other way, that, when we're uncomfortable, it's often because we're uncomfortable with the situation, and that usually means we need to intensify care. When we do follow-up visits, it's just like regular other medical problems. You want to sort of figure out what's going on around all the other things that people are often using. You want to see how people are doing the medication, whether it's working, whether the dose is right, whether they're taking it right. There are a few special things around buprenorphine. So some of the common ones are around like safe storage, and then asking for some of the things that are signs that things might not go as well going forward. And so those would often be like cravings and triggers, or things that typically might lead to a return to use. So asking explicitly about those can be helpful. And then just like just like other mental health conditions, nothing goes right when people aren't sleeping well. And when people aren't sleeping well, it impacts mood, pain, social function. And so focusing on just some of the basics around wellness management is well worth it in this situation. And we're going to talk a little bit about counseling and other psychosocial treatments. There've been a number of good randomized, there've been a number of pretty decent studies showing that that counseling doesn't really seem to get a lot of benefit over the medications alone for patients with opioid use disorder. That being said, I think all of us who've seen patients for a long time recognize that for people to really have sustained long-term stabilization or recovery in their life, they often need counseling of some kind, just like probably all of us do. I could probably use some counseling too. And then urine drug screening is one of the only sort of really objective evidence that we have sometimes of how stuff is going. So you can get a lot of information with talking to people, but urine drug screening can be an important supportive mechanism for patients who are in treatment. In terms of dosing of buprenorphine, it's FDA approved for once a day dosing. Most patients prefer to take it twice a day. And so that's how you'll probably see it the most commonly. And then for patients who are also using it for pain, it's often dosed 3 times a day or even 4 times a day. But obviously 4 times a day is pretty hard for people to do unless they are very, very connected with their medications. And so TID dosing is often one of the little cues you can look for that maybe this is being prescribed partially for pain. And we tend to not prescribe PRN doses after people are stabilized. The idea is that these are long-term medications that come on slowly, occupy the receptors, and are kind of a smoothing function to both protect patients from overdoses, but also to get people out of the cycles of taking drugs, seeking drugs, recovering from drugs. Cravings are a really important cue to look for when we're seeing patients back, because they trigger return to use, or some people use the word relapses. And so we know that buprenorphine does a pretty good job at inhibiting cravings, which is great because it makes people's life better, makes it less likely that they're going to use other opioids. But not all cravings are really due just to the absence of a medication. And we all know stories of probably of our own and our patients, right, where cravings can be for all kinds of things, whether it's food or drugs or anything, can be triggered by other cues or stress. So, that's why you often hear from someone who's in alcohol recovery that they drive by the liquor store they used to go to, or the house where they used to drink with friends. Or we hear from patients who are using other drugs, that they drove past a place that they used to buy drugs or use drugs, and those can trigger intense cravings, because as Dr. Morrow said, these are evolutionarily very solid parts of our motivation system. And so, historically, like we wanted to remember where food was, and one of the ways that we get that signal is by connecting things that are pleasurable with parts of our memory. I was just reading some cool study about how honeybees that go to flowers that have caffeine are much more likely to go back to those flowers for nectar than the flowers that don't have caffeine. Also dopamine release. And cravings go up and down throughout the day, and so it's one of the reasons that you'll often hear people who are talking with patients say, like, you can feel whatever you feel, just feel it, and then, but before you do anything, wait 5 minutes. And those are often tricks that people use to get through these dynamic and changing things. In terms of monitoring and management, as Dr. Morrow mentioned, some of this is, I was going to say made up, but that sounds too negative. I would say some of this is based on expert opinion or idiosyncratic. Really, there's nothing as risky for people's liver as alcohol or getting Hep C, which ends up being the kind of end result for lots of patients who especially are injecting drugs. But we tend to do some lab work at some intervals. Some people do 6 months, some people do 12 months. And it is important to keep people up to date on preventive care stuff, especially hepatitis, PrEP for people who are at risk for HIV. And then one that we don't often think of as harm reduction, but kind of is, a lot of, maybe 50% of all pregnancies are unintended, or unplanned is another way of putting it. But that rate's even higher in patients with opioid use disorder. And so LARCs, so, Nexplanon, IUDs, long-acting reversible contraceptions are good options for people. And sometimes it's something that's that we forget to offer. So a few tips, kind of like tips of the trade. You would like to try to give people enough medications to get them to their next visit. And I know that sounds probably basic, but it's, as those of you who prescribed other controlled substances know, it's more annoying to do controlled substance prescribing, right? Because most people who have an electronic medical record, they need to log in, they need to go into maps, they need to fill out a prescription. So it's really a waste of time if people run out of medications a day or two before their visit, for example. So you want to try to prescribe the correct amount of medication to get people to their next visit. Michigan and everywhere can do this. The films are splittable, so they can be cut, and you can prescribe it that way on the prescription, but it definitely works that way also. And in Michigan, Medicaid covers a max dose of 24 milligrams of buprenorphine. So either 2 12 milligram strips or 3 8 milligram strips a day. And a few other things we occasionally see is some people, it'll cause difficulty with sleep. So sometimes we'll move the doses earlier in the day. And if people are nodding off or seem really activated, it can be a dose issue. Urine drug screens are important, partially because they're an important part of monitoring of treatment, but also they're a major source of breakdowns in patient clinician relationships, and are a big source of stigma for patients also. So in general, one way of converting how people think about it is making sure that we know that, like other tests, it's a test we do for the patient, not to the patient. We're not law enforcement. And that, patients can sense the difference between doing something that is supporting their recovery versus doing something where you're trying to catch somebody in a situation. It can be really helpful because it's objective for the most part, but we'll talk about some of the downsides. can aid in monitoring and diagnosis. It can also support people in recovery. Just knowing that they might have a drug test can sometimes get people through some of those difficult little bumps. And we know it can increase communication. And the reality is, once people have good relationships with patients, you often rarely, you already know what the drug test is going to say. Oh, yeah, go, hey, Dr. Frank, like, yep, I had a slip, I did it. And so knowing that is one of the ways that you can tell how your communication's going. You want to get to the point where people are giving you an accurate, honest assessment of what's going on. We'll talk about getting to know your test in a little bit, because I would say urine drug screens are one of the more easily misinterpreted tests out there, and it is just like it's just kind of a little bit complicated. In terms of the frequency, I think almost everyone does it at the time of initial evaluation, and early on in treatment, do it at most visits. I think it's gotten more important in some ways now, but also more challenging. So it's gotten more important because sometimes patients no longer know what they are getting. And that part's a little weird. People used to be fairly reliable about telling you what they were taking. But now there's so much fentanyl contamination in the drug supply that it can be hard to know exactly what people are using. So people can be thinking they're using methamphetamine, but it can have fentanyl in it also. Same can be true with cocaine, or Dr. Morrow was talking about benzos, pressed pills, where those can be contaminated with fentanyl. The reason it also is more complicated is that a lot of urine tests don't detect fentanyl, so it can be complicated. Usually we use urine because it's cheap, like the little cups that we use in the office, that might have 10 individual tests in it. So for 10 different classes of substance are usually like only $3 or $4. And you can also set these things up to test for buprenorphine and other metabolites. This was maybe more important at the peak of COVID, when a lot of people were quickly converting to telehealth for patients with opioid use disorder. And I had written on my sheet, I know there was a question about telehealth and buprenorphine that we can talk about too. But in general, one of the concerns about telehealth for buprenorphine is around this issue of urine drug testing and difficulty getting this objective piece of data. And I think this was the American Society of Addiction Medicine. Places should carefully weigh the risks and benefits. As always, it's prudent to avoid ordering tests that won't change a patient's management. And so I think that highlights the main issue, which is, polysubstance use is really common and normal. Lots of patients who are going to be using opioids may also use other things. But the reality is that for most patients, the fentanyl is what kills them. And so, it's pretty uncommon for us to turn up something in routine urine drug screening that would make us stop someone's buprenorphine. They often are conversation starters about, figuring out what else is going on in people's life, or why they're needing to use some other thing. But usually the answer is not to stop the buprenorphine. The one case that I think is an exception is this very, very small number of people who don't take their buprenorphine and instead sell it or trade it for other drugs. So detecting buprenorphine is an important part of treatment, mostly just to make sure that the patients are using the medication. This one probably is going to give everybody a seizure, but I think the most important take home from this is that So urine drug testing, when it says an opiate, it has the opiate section. It only detects naturally occurring opiates, and so that's morphine for the most part, codeine, and then heroin, because heroin is diacetylmorphine, and so heroin, morphine, codeine, they all test positive. When you get down into the semi-synthetics, buprenorphine would be in here, but it's not. It should be in here, but it's sort of off. These are harder and oftentimes need to be tested for directly. So that's why there's like the oxycodone one in most people's test. And the synthetic ones like tramadol, fentanyl, methadone, and buprenorphine aren't picked up in these tests unless they're specifically tested for. So people can go down a path where they get screwed up. So essentially, someone is being prescribed buprenorphine and their opiate is negative. And someone who doesn't understand the tests says, "Oh, you're not taking buprenorphine." And the person says, "Yes, I am. I totally am." And it can create a real breakdown in the therapeutic relationship. So the answer is, when you get an unexpected result, you want to do confirmatory testing. So whether essentially it's just like a screening test that you might do in other parts of medicine. When you do a screening test and you get something unexpected, the answer is usually to do a better test. This talks about the detection windows and the immunoassay. So these are the urine, P tests and the thing. And it's usually in the 2 to 3 day range. As you know, probably that, daily cannabis users, it can hang around for a long time because it's hangs around in the fat. But for the most part, we're talking about a few days for some of these things, but they're all very dose specific, and it can get complicated, right? So, and some of you have probably seen that it gets complicated. For example, with people who are taking amphetamines for ADHD, sometimes these urine drug screens will pick them up, sometimes it won't. And that's because these tests were originally mostly designed as employment tests. And so they have fairly high cutoffs. And so while they'll pick up methamphetamine, they might not pick up someone who's using an amphetamine salt appropriately for their ADHD. There's lots of examples of false positives and false negatives. And this can also be like a area of pitfalls, I would say, in terms of just being complicated. So there are antidepressant medications and beta blockers that can cross-react with the amphetamines. Some of the SSRIs also can cross-react with benzos. Opioids have obviously like well-known, movie version, the poppy seeds, but also diphenhydramine, so Benadryl. PCP is like, we don't hardly see PCP at all. Like most of what we see is false positives for those. And sometimes cannabinoids can be difficult too. Might disagree. You gotta really be in a heavy secondhand exposure to be positive. But the answer when you get unexpected results is to do a confirmatory test. And most common confirmatory tests are liquid or gas chromatography with mass spec. And these are much more accurate. And if they're, you still have to know some about them, but it can be a way to look for things like fentanyl, also things like metabolites of buprenorphine, that sort of guarantee that it's gone through the metabolism system in the body. So norbuprenorphine is the common metabolite of buprenorphine. But there are still variables, and you still have to understand your test. But the take-home message is, when you get unexpected results, what you want to use it as a conversation starter. You want to send confirmatory testing to understand what's going on. You don't want to immediately like ruin your relationship over a screening test, because they're not consistently accurate. And you don't want to use screening tests to make clinical decisions. You really want to get the confirmatory test so you understand what's going on. Other things that can support people's recovery are all of the different psychosocial supports. And like I mentioned, and I think the next slide shows that there have been some RCTs showing that these behavioral therapies don't necessarily add a ton in terms of, all-cause mortality. But like I mentioned, they're really important for people who are looking for, not just to change their relationship with a substance, but also a lot of the things that may have put them at risk for substance use disorder in the first place. So some people find mutual support groups helpful. Obviously quite helpful in alcohol use disorders for people. There are groups that are specifically designed for people who are, patients who are on buprenorphine. But some patients will find that they're, less welcome in certain kinds of groups than others. And it can get, it can be other things. These can be other things that are stigmatizing. Individual and group therapy can be helpful. Oftentimes a lot of bridges have been burned with families. And then there's a full range of, intensive outpatient programs to residential and other more intensive programs. In terms of referring to therapy, I think, the ASAM recommendation is that all patients should be offered psychosocial support, but they shouldn't be denied medication if they decline that support, mostly because all the evidence shows that the medications do a really good job at decreasing people's risk of death. And, a lot of times in the early part of treatment or early recovery, people are just not like very in a good spot to really engage with behavioral therapy. And oftentimes as things start to like smooth out a little bit, people have, broken out of that cycle of, seeking, using, recovering, and they've opened up a lot of time in their day. And often they'll be much more ready to engage with treatment. We also had a question earlier about duration of buprenorphine. It was actually on the other end, which was, it was someone who was working in a community mental health setting was saying like, we have some people who are doing so well. They like are totally stable and they don't need our other community health resources. And we just want somewhere for them to go so they can continue to stay on their buprenorphine. But we also see the other end of it, both where patients want to not be on buprenorphine anymore. And occasionally when clinicians have, more firm timelines about how long they like to treat patients with buprenorphine. But as Dr. Morrow mentioned, pretty good evidence now that when people stop their buprenorphine, there's a large increase in overdose risk and return to use. And so that's not really that surprising. I don't know, in some ways I think of it as like my patients with diabetes. I have some patients who have diabetes and they find out they have diabetes and they're willing to take medications and they do a few other things, they improve their diet a little bit. But if they stop their medications, their diabetes, just flares right back up. That being said, we all know the other examples, which are like occasionally I find we find someone that we diagnose with diabetes and they have like a come to Jesus moment, right? They like join CrossFit and they decide they're going to run a marathon and they become, they're a plant-based athlete all of a sudden. And that's the kind of lifestyle changes sometimes it takes especially with opioids, if people really don't want to be on anything. And so there's a wide range of different ways of looking at it, but for the most part, we encourage people to continue while they're doing well. And when they want to talk about weaning, then we talk about the risks and benefits, and usually we try to help people do it while maintaining an off-ramp and a way for people and the people who care about them to know what's going on, so that if things start going sideways, they don't have to go all the way sideways. So SAMHSA has this so tip 63, you'll see referenced a lot. It's got a lot of information in it. And, so they recommend the same thing, for as long as it provides benefit. It's called maintenance treatment. It's in some ways you can think of it like we often use methadone for MOUD at outpatient treatment centers. And some people will stop using illicit substances, especially illicit opioids, because it ends up being a waste of money, because people don't get the same high feeling. But sometimes people just slowly pull back and use less or in smaller quantities, which does have a benefit. It reduces their risk of morbidity and overdose death. And so, like Dr. Morrow said, a lot of people have returned to use if they stop. Longer retention in general has better evidence. And, I think very few people recommend a rapid taper. There used to be some people who did that because there were Medicaid requirements about how long you could treat people. So there can be this like external time pressure to discontinue things. But for the most part, slow is better, because that allows patients to sort of see how they're going to do without having all of their tolerance gone. Because, if you go from 24 milligrams of buprenorphine and then over a month or so, for a few weeks, you decrease to 0, you pretty quickly lose your tolerance. And in those situations, when people return to use or have a relapse, sometimes, especially with our current drug supply, sometimes you don't get many chances at that. So it's really scary. These discussions always come up, and being curious about why they want to taper is like the first step. And there are all kinds of different reasons, but most of them have to do partially with stigma, but also just because, no one wants to be on medication, especially if they're feeling good and feeling like things are going well. But you do want to make sure people understand about the loss of tolerance and having a plan, and having someone who cares about them know the plan. And hopefully having dealt with some of the other things in their life that are now more stable. In this crew, we don't have to talk too much about MAPs, because all of us use the PDMPs anytime we prescribe controlled substance in Michigan. There's still some issues with communication between state programs, and it's important to know that the information for the PDMP feeds in from pharmacies. So there are places and kinds of medications that don't show up there. Biggest one being methadone. So methadone from an outpatient treatment program is dispensed there, so it doesn't go through a pharmacy. And so that's another area where people can get hung up sometimes. Someone will say, I'm on methadone, and someone will look up in the PDMP and they'll say, no, you're not. And they'll say, no, I swear, I go every day. And so knowing some of the nuances can just avoid like difficult conversations. Pill counts. So these are the ideas that you might randomly break someone in to check on their buprenorphine supply. These are, most people don't do these. and we probably should take the slide out. I'll just leave it at that. It's kind of time consuming, ends up, you know, feeling a little bit judgy, I would say. And, you know, we don't do this with other medications that we also know are diverted at some rate, right? So like, I can't do it here, but, you know, if I asked everyone on this call if they have any antibiotics or muscle relaxers or pain medications or anything at their house, some of us probably do. And those are all versions of misuse. And misuse happens with buprenorphine also. The reality is when buprenorphine is diverted, it's usually used for people who are trying to blunt withdrawal from other opioids, or people are trying to self-treat their opioid use disorder, especially in communities where treatment's not very accessible. Places that have really, really low barrier buprenorphine, the street value of buprenorphine like goes to the floor, because it's not the drug of choice really for hardly anybody. There's big like treatment databases about publicly funded treatment every year, and the number of people who have a primary a substance use disorder to buprenorphine is like, I think the year I looked, 2021, was like 13 people, you know, and we're talking, you know, hundreds of thousands of admissions for opioid use disorders. I think one of our colleagues, Shiba Sethi and Dan Berlin, enjoy this quote, you know, just because you've gotten the monkey off your back doesn't mean the circus has left town. And it's really the reminder that, you know, this is the stabilizing force for a lot of people who are in treatment from their opioid use disorder, but it's not a magic. This is not like a, you know, Willy Wonka type situation. You know, it doesn't treat non-opioid drug use, doesn't resolve people's, you know, doesn't always resolve mental health issues. Although I will say that some people have substance, you know, driven mental health issues that are improved significantly with buprenorphine. Doesn't necessarily make it magical that people are going to adhere to all of our recommendations, and it doesn't resolve all of the other psychosocial stressors that many people have. And so when we're thinking about what kind of timeline we're talking about here, we're talking about induction, you know, resolving acute withdrawal symptoms in this like days to weeks kind of time. Often people will slow their use of other opioids in weeks to months. And some people, but not all people, will start to get stabilized with some of their other psychosocial issues, and sometimes will pull back some of their other substance use. Recurrence of use is essentially return to substance use that occurs usually in response to stressors or stimuli or cues. And you all know all of the things that can precipitate it. You know, we all know that it's very common, right, to see someone who's returned to use who broke up with a boyfriend or girlfriend, had death of a parent, lost a job under family stress. Boredom is a big one. You know, you guys probably know that study about where you put people in a room, and if they have the option of just sitting there bored, or giving themselves a little electric shock, most people will choose to give themselves a little electric shock. You know, we really don't like being bored. Some of the things you can do to help people are to sort of preemptively think about some of these things. And that can be pretty helpful for people to just like, hey, you know, when was the last time you had a craving? Where were you? What did it feel like? Does that always happen there? Like, can you think of any ways that you might avoid that? And sometimes people come up with interesting ways of not triggering those feelings. And, you know, helping people really embrace sort of a growth mindset around that, you know, treatment is a learning process, involves good times, bad times, mistakes, and using is more of a mistake and an opportunity to learn something, and that can help people change their perspective about their own illness. And when things aren't going well, you want to intensify care, review your treatment plan, and sometimes that will be with you. Sometimes it might be with someone else if someone needs additional help or a different level of care, more intense level of care. Polysubstance use is the norm, and we probably unfortunately know this like much better now than we did in the past. And it's because we have all these deaths and all of these coroner reports that involve pretty sophisticated testing for substances and their metabolites. And so we know that there's often a lot mixed in together. Unfortunately, it's also the reason that buprenorphine by itself is not the causative agent, even in patients who are using buprenorphine. It's often this other stuff, including alcohol. So overdose risk is increased when people are using multiple things, because sometimes people are using two things that try to balance each other out a little bit so they can mask each other. And one of the most famous studies in Massachusetts, was an observational study looking at real life situation where people came in after a non-fatal overdose, and the people who ended up using buprenorphine or methadone afterwards as part of their treatment had a reduction in all-cause mortality compared to other people, even though they didn't like cherry pick out like some studies and say like, oh, we're only going to take people who just have an opioid use disorder. They took all comers, and most of those patients had other stuff. So we have a quick case here. So, and I think this goes back to a question that someone asked earlier. So we have a 35-year-old woman with diagnosis of severe opioid use disorder and a moderate cocaine use disorder, and she's been treated with buprenorphine, 16 milligrams daily for 6 months, and stopped using heroin, which you've confirmed by urine drug testing. And her urine drug tests show evidence of continuous cocaine use. How will you respond? And does the nature of the substance affect your treatment plan? And I don't know if anyone can unmute if they want. They can put it in the chat. Probably many of you know this, but one of the little tricks or like a board type question is that the cocaine test in urine is pretty good. So there's lots of false positives and false negatives for some of the other stuff, but the cocaine test is pretty good. And so when people show positive for cocaine, it's usually true.
Yeah.
Does
So
anyone have? Go ahead.
I was just going to say, I'm the one that asked the question.
Perfect.
The thing that's interesting about this is like nowadays, a lot of the cocaine is actually like mixed in with other things, which makes this a little risky. But if everything else is negative on the drug screen and, the cocaine is positive, I feel like I personally don't see anything wrong with continuing the buprenorphine, as the benefit likely outweighs the risk. But now that everything's like laced with something else, that might change my mind.
Yeah, no, I think that's interesting. Yeah, I mean, in some ways, the mixture of fentanyl into other parts of the drug supply has like almost taken this off the table, in the sense that cocaine use used to just be cocaine use, and now cocaine use might be cocaine plus fentanyl use, and actually being on buprenorphine probably decreases the risk of her death from fentanyl that might be in her cocaine also. It's hard to know after people die you can't ask them, what did you think you were taking? Mostly you're looking at what showed up in their tox screen and on their autopsy. And so if someone shows up with cocaine and fentanyl, it's hard to go back and say like, so did you know you were using fentanyl, or did you think you were using cocaine? So I would agree, and I would even extend it beyond what you said, which is like, even if there's other things in the, maybe I think the more other things there are in there, the more important it is that this person's on buprenorphine, because they're at an incredible risk if they're using a mixture of stuff, and some of that includes fentanyl. I think Lauren has a good point about using this as an opportunity to open a conversation about, you know, why she's continuing to use cocaine. So, you know, discussion, you know, motivational interviewing about what is this doing for you? Good, bad, indifferent? What are your goals? How does this fit in with those goals? Looking for areas where there's maybe a gap that you can plant a seed. How about I think maybe I already said, I guess I probably already stole this one. Does the nature of the substance, stimulant versus benzo, affect your treatment plan? I think in the past it might have. You know, it felt scarier when people were using a lot of illicit benzos and buprenorphine, because, you know, you just worry that there's some risk. But now that so much of the synthetic benzos or illicit benzos also have fentanyl in it, I think it's harder to make that argument. There's just very few situations now when people are using multiple things where buprenorphine's the risk. It's usually all the other stuff, and actually the buprenorphine is one of the only protective things that they have. So we got another one here, Kevin, and this one answers another question, or maybe it brings up the same question that's been brought up in the chat around methadone and Suboxone. So 31-year-old man with past medical history of chronic hep C and opioid use disorder, and he wants to come in for hep C treatment. And he's on this normal dose of buprenorphine for 8 months, and he lives with his wife and daughter, and he gets buprenorphine from a cash-only provider about an hour from his house. He's gotten a second job to pay for the monthly visits and prescription. So he's never had any labs checked at his provider, and he's diagnosed with hep C when he was in jail. And he asked the question, you know, or maybe it's a statement, that it's much easier to keep doing heroin than to get treatment. This is actually a real patient from one of our colleagues from Sheba, Dr. Sethi. And she uses an example of, you know, how it can be a little bit messy, and that's okay. So, you know, this was his real course, you know, that he continued to work and do okay. He was, you know, home taking care of his family, and he called a week before his prescription was due because he said it had been stolen, which is, you know, always kind of go, His drug screen was positive for buprenorphine, but also for cocaine. And then he reports having back pain, and he took extra dose, and that's why he ran out early. That being said, he also expresses appreciation, gratitude for opportunity to be treated and ability to function without that cycle of continuing to use IV drugs. And so, you know, I think this is Sheba's slide, but, you know, this is abstinence from all substances is not necessarily the standard of what success looks like. Just like, you know, being med free is not the standard of what success looks like in treatment of coronary artery disease or diabetes or schizophrenia or, you know, all kinds of medical conditions. So that is that section. We are right on time. Feel free to throw some stuff in the chat if you have any while I pull up the next thing. So we've been talking a little bit about some of the stigma around substance use disorder in general, kind of sprinkled throughout, but I want to be a little bit more explicit about some of this stuff. Some of the language stuff that we're going to talk about can be a little bit challenging because, lots of us have learned different kinds of ways of talking about different things over the years, and sometimes it can be hard to change our language. But how we talk about things and people can have some impact. It's also a little complicated because people with substance use disorders will often use stigmatizing language about themselves, right? It's very common to hear someone say, I'm an addict, or I'm a junkie, or whatever. And we want to make sure that we're not reinforcing those stigmatizing languages. So the general term that is used is medication for opioid use disorder, or MOUD, and that includes the 3 FDA approved medications. So that would be Vivitrol, the injectable, naltrexone, buprenorphine, and methadone. And the reason we've taken away some of these like medication assisted, these kind of things, is from the studies showing that the medicine actually provides all the measurable benefit. Doesn't mean there's not other benefits, but all the measurable benefit that we have from studies. So there's a few common myths. I don't know myths, but misperceptions, and sometimes can come from patients, sometimes can come from staff. Probably some of you will hear it from other clinicians in your community, and so it's good to have a good answer. And so one of the myths is that MOUD just trades one addiction for another, and you can see why you might say that, right? So someone's using heroin and you switch them, and now they're using buprenorphine. But the way I think about it is to go back to the diagnosis of an opioid use disorder that Dr. Morrow covered. So, it's these long lists of things that are going wrong. And so, it's the people have lost control, the inability to cut back, their use in spite of negative consequences, that screwing up their relationships, screwing up their jobs, all this stuff. So addiction is not that you have tolerance for an opioid and that you use it as prescribed. Addiction, or substance use disorder in this case, is that you're not using it that way, and your use of it that way has had all of these other problems. It creates all these other dramas in your life. And so, so Jessica wrote, sobriety is not just abstinence from the drug of choice, it's also abstinence from the lifestyle and all that comes with it. That's a better way of saying it. I like that one. And, it's actually, it's called opioid substitution therapy in some parts of the world. But we use these stabilization approaches in other things too. So, we use nicotine replacement therapy. We use some vaping of nicotine products as a harm reduction approach. Actually, varenicline, so Chantix, is actually very similar to buprenorphine. It's also a partial agonist. So we use these kinds of approaches for lots of different things. Another myth is around diversion, and this slide is very challenging to read. And so what I'm going to do is, I think, go this way. So the misuse potential of buprenorphine is there. We know that there are patients who misuse buprenorphine. And so there's a few things to know. It can cause euphoria in individuals who are not opioid dependent. Reality is that you can't use it very long without becoming opioid dependent. The misuse potential is less than the full opioid agonists like oxycodone, hydrocodone, all of the normal ones that people are prescribed. And partially that's because the mixed, the Suboxone product is the abuse deterrent mixed in. And that's why the combination product is theoretically less likely to be misused. Definitely, there's more of a euphoric effect if people take it in a way that's fast acting. So that would be, injection usually. But most of the buprenorphine that's diverted is used to prevent or treat withdrawal or cravings. Short answer. And when we ask people the reasons that they're using buprenorphine, this is from patients who are in a syringe service program. I think this one's from Washington State. The highest percentages are maintain my abstinence from other drugs because I was trying to wean myself off. And then these other ones that are high, hold myself over during work events because I knew I wouldn't have access to other drugs because my drug of choice wasn't available. And the number of people that you say that it's because it gives me a better high or because it's my drug of choice are tiny. And I mentioned this treatment admission database. I think I said 2021, it's 2019. And so if you look at like the 400,000 treatment admissions, publicly paid for treatment admissions in the US for the broad family of opiates, 280,000 for heroin. This is kind of pre-fentanyl. And you can see, oxycodone, hydrocodone, and buprenorphine were down here 13. Like that's even lower than ones that we never see, like Darvon, which is very old school. MOUD in general, so buprenorphine, methadone, are associated with a reduced risk of opioid-related overdose. And not to just bang on a dead horse here, but this is what we're seeing now is that even a single use of opioids after people have gone through either a voluntary or forced detox, so jail, prison, or a detox facility that doesn't offer transition buprenorphine, all of those can result in an increased rate of life-threatening or fatal overdose. In terms of reducing stigma, it's really this feeling of humiliation that people get, or mark of shame or discredit. And, people do it to themselves. People's family do that to them. Medical providers are notoriously terrible about stigmatizing patients with substance use disorders. And these types all kind of feed together. So you'll hear people with a lot of internalized stigma. It's why, you almost never see somebody who's lost control of their substance use who is happy with themselves. Like they've always tried to quit 100 times before they see you. They're really frustrated because they don't understand why they can't get on top of this by themselves. You also see some sorts of stigma within different recovery communities. There often tends to be recovery communities can often be started or anchored around people who are in recovery themselves. And there are many different pathways that people take to get to recovery. And often we don't understand why some stuff works for some people and some stuff works for other people. Dr. Morrow mentioned that 10% of patients who essentially don't return to use from their opioid use disorder, and it's really hard to predict who those 10% are, which is why it doesn't really work and why we recommend in general treating everybody with some sort of protective medication. But if you're in that 10%, it can feel like other people should be able to do it the way you did it. And so that can create some tension and stigma. There's stigma from clinical providers, and I was just reviewing some data on this. Maybe, I don't even know if we have the slide, but you'd think that we would get better at it over time, but it's not really true. Some of the most stigmatizing providers tend to be older. And I've noticed this in our medical students and residents that we teach, that they often have a much more well-tuned anti-stigma approach to patients with substance use disorders. And it's a good reminder for those of us who've been doing it for a while that that just because you've done it longer doesn't mean you have it figured out. And there's obviously strong public stigma around substance use disorders of all kinds, and we see this, in almost every community that we work with around the state. Oh, I did have the slide. Yep, healthcare professionals are the most commonly cited source of stigma for patients receiving treatment. It's a bit embarrassing, when we certainly stigmatize other physical concerns, obesity, other mental illnesses, but when they do studies, substance use is the worst, and seasoned clinicians are some of the worst at it, something to chew on. In terms of changing language, we usually recommend person-centered language. So, a person with diabetes, person with a substance use disorder, not this diabetic, this alcoholic, this. In general, we try to use recurrence or return to use instead of things like relapse. And we talk about positive, negative, unexpected, or expected, things like urine drug screens or tests, other than clean, dirty, those kinds of things. Some of the best ways to address stigma are to provide other harm reduction services, because it shows that you care about people in a very concrete way. So, offering people treatment without making their ability to not use drugs a precondition for how you're going to treat them can be quite destigmatizing for patients who maybe haven't been treated very well for a long time. And so expanding evidence-based options, offering sterile injection equipment or referrals to syringe services programs, offering naloxone distribution, which is, the reversal medication, and then trying to use language that clearly shows that you value people, can all be things that make people feel just a little bit better. And oftentimes people are better able to make changes when they're feeling a little better than when they're feeling worse. And when we compare SUDs to other chronic diseases, they have a lot of the same features, right? They're, partially genetically determined. They're influenced by our early environment and our behavior. So both choices and our environment. They can all be difficult to treat, but in general, treatment works better than not treatment. And all of these things, if you really let them run, can be really life-threatening. I would say that one of the things that we do know, though, about substance use disorders, less about opioid use disorder, but for a lot of the other ones in particular, there are a lot of people who do recover. Like if you look at big groups of people who have substance use disorders, so there is a positive story in that, and it's not all doom and gloom. Jessica wanted to know if we'll get the slides out there, and yep, your behavioral health consultants will be sending them out. And so this just drives home the discrepancy about how we treat some chronic illnesses and how we treat substance use disorders, sometimes in a more stigmatizing way. And I always think about how we act when our patients with diabetes say, oh yeah, I went to a wedding, man, I crushed a whole cake or whatever. We wouldn't withhold their medications or kick them out of treatment or do any of those things. Those are all times that we would try to intensify care, come with some curiosity and try to meet people where they're at, and just treat people kindly. Some of the ways to challenge stigma are, trying to be open and mindful about our own language, but mostly I think it's actually just being nice to people. I'm always amazed at how often it takes very little for people to feel that they're well treated. And it's often because they haven't been well treated for a long time. And it's often also because they really, really are upset with themselves and they have a lot of, internal, I don't know if it's stigma is the right word, but they don't feel good about themselves. And so anything you can do to find something positive to say to them seems to make a big difference. That's the end of that one. We're going to take just 5 more minutes and then we're going to be, well, it might be more than 5 minutes. We're 1 minute early, but we're right on time. Stop this one. Any questions in the chat while I switch this up to our last section? So the last section is around pain management, and this is a good one because we get lots of calls about this issue from different parts of the state, and yeah, it's good to know. It's good to know how to answer the questions. So we have a few different categories of situations that come up often. One is like, how do you do pain management with patients who are doing well and they're on buprenorphine and then something bad happens? They have an accident or they need to have a surgery. How do you handle that? And then there is, more and more evidence that for the small number of patients who do benefit from opioids for chronic pain, which is not a lot, but some, often buprenorphine can be a safer choice than full agonists like hydrocodone or oxycodone. So in terms of just understanding increased pain sensitivity, patients with opioid use disorders usually have less pain tolerance on average than matched controls. Doesn't mean every single person does. This is on average, but definitely see it. But I'm not currently working in the inpatient addiction on an addiction service right now, but very common after surgery, for example, someone who has an opioid use disorder needs more pain medications than someone with the same surgery who doesn't have an opioid use disorder. Maybe one of the most prominent, I deliver babies, and so for mothers who are in labor, epidurals are going to be the answer for most patients because they do tend to have less pain tolerance. Epidural, if it was me, would be my choice anyways. But clearly there is a bit of a difference. For acute pain management for patients who are on an opioid, so people who are physically dependent, so they're taking methadone or they're taking buprenorphine, essentially they need to stay on those same medications. There used to be this idea that maybe you needed to stop them so you could give them something else. Really that creates almost a system where you're causing a bit of withdrawal and then trying to chase it. And so we know that you need to maintain people's daily dosing of their chronic things. And then you're going to need more opioid medications due to higher pain sensitivity and the tolerance that has developed to either this, and this is kind of relevant for both buprenorphine and methadone. And so you always want to do everything you can do that's not opioid related, so multimodal pain management. So this is like Tylenol, ibuprofen, lidocaine patches, muscle relaxants, local blocks by anesthesia, catheter or epidurals, all of those things that can help manage pain. And when you do need to use opioids, usually you're going to need to use a higher dose. And the rule of thumb that we usually use is that you start with about 1.5 times of what the usual amount would be. So if a person who's not opioid dependent needed 10 milligrams of oxycodone, usually after a certain surgery, we usually start with 15. The other move is to split people's buprenorphine dosing up. So switching it from twice a day to 3 times a day. And in an outpatient setting, sometimes we'll just increase people's buprenorphine for a little while after like an outpatient surgery to get them through. In terms of thinking about things where you have time to plan, acute issues are one thing. You have to do kind of one thing. For people who can plan it out, in general, we just continue people's buprenorphine unless they're really high doses. And there are some guidelines on the MOC website that have a flow chart that can kind of direct you through that. And essentially it's this. So, this is the most common. So surgery with moderate or severe pain, and they're on a normal dose, say 16 milligrams. And so in this situation, say they're at 16 milligrams, they just continue their home dose and then it gives them some instructions on what to do the day of surgery. For people who are on 24, often we'll cut them back to 16 just the day before surgery. And that's really just to allow a little bit, some of the mu opioid receptors to be kind of available for other pain medications. So this is all on the website. For chronic pain, this so much is changing in all these areas. Like, right, a lot of the opioid epidemic kind of started from a sort of like an approach to chronic pain that wasn't strongly evidence-based, that involved too much use of opioids that were pushed by for-profit type people. And then those of you who follow this closely know that, CDC in 2016 made some recommendations that talked about safer prescribing. And we know, those of us who are kind of embedded in this know that there were a lot of unintended consequences from that. So people got scared to prescribe opioids for pain. They pulled back their prescribing. We saw an increase in suicides among patients who had chronic pain and had their medications cut off. We also saw some people transition from, pain pills to heroin or other things that were cheaper. And now we're seeing the pendulums kind of swing a little bit more to, I'd say, a neutral position, which is, there's no big hurry to cut people off of other opioids if they're doing well. But we really should not be going to opioids as a first or even second or third line choice for chronic pain for most people. The better approach usually is this, which is, trying to find local pain generators and treat them, deal with all of the things that may make pain worse. So poor sleep, other mental health disorders, and all of the healthy behaviors that decrease pain. And then know that for patients who are getting pain medications or opioids, understanding this continuum from using medications to treat pain to developing tolerance, and then an opioid use disorder in some patients. And so the new CDC guidelines are, here from 2019. So, chronic pain and not receiving an opioid essentially recommends avoiding opioid therapy and trying to use another approach. For acute pain, you occasionally will need opioid therapy for severe pain, and you want to limit the dose and duration. to try to prevent development of opioid use disorders. And then for patients who are in chronic pain and receiving an opioid therapy, we don't try not to do anything dramatic around abruptly tapering, discontinuing, or breaking therapeutic alliances. And this is a group of people right here where we often encourage people to try transitioning them from a full opioid agonist like oxycodone or hydrocodone, or sometimes methadone, or fentanyl patches to something safer like Suboxone. Should consider transitioning patients on full agonists to buprenorphine when you're getting benefits, but it's only working some of the time, or when patients are in trouble. And this is the common one, was, it's just not working very well. The dose is escalated. People are asking for more. They have a history of a substance use disorder, or they're developing one. And so the buprenorphine talk is more and more common now, and you have to use all your skills for it. And I find it hard. I think everybody finds it a bit hard. And so, since buprenorphine has been stigmatized in some ways as a medication for patients with an opioid use disorder, it can be hard to talk to people about that don't have or don't think they have an opioid use disorder about using it. The reality is buprenorphine really works well for pain, and that's how it was initially used. And there are a number of FDA approved versions of it that are specifically for pain. And so we just wanted to throw those out there so people have seen them if they don't know about them. But you need to have a really good relationship to have these discussions, because if patients are not up for it, then it tends not to go well. And when they're ready for it, sometimes it tends to go great. The benefits of buprenorphine over the full agonists are that lower risk of overdose, lower side effect profile, you see less tolerance, it's easier to prescribe because it's Schedule 3 and Schedule 2. Some of the disadvantages are cost and insurance issues, although those have slowly improved as the insurance companies have figured out the same thing, which is like, it's actually safer, causes fewer problems, and so it becomes more cost effective for them. One of the main forms that you can use, it goes by the brand name Butrans, but it's a transdermal buprenorphine. There's also a generic one, and it's dosed in micrograms. So these are low dose formulations of buprenorphine that work well, and essentially they're easy because you just slap the patch on and slowly titrate it like you would another long-acting medication. So you give it a week at a time before you make changes. Some people develop irritation. You can treat it with a steroid cream or Flonase. Historically, it hasn't been well covered, but it's more well covered now. Another formulation is a mono product, so only buprenorphine, doesn't have the abuse deterrent, but again, the dosing is really small. So the dosing of buprenorphine and Suboxone is in milligrams. These are in micrograms. And so if you were looking at that early graph that Dr. Morrow showed, which is like the dose dependence of opioid activity and buprenorphine, when we're doing buprenorphine for opioid use disorder, we're out in the flat part, where all the receptors are occupied. When we're using it for pain, we're using it down in the lower left corner of the graph, where small changes in dose are more linear. And so this buccal preparation also works quite well. You can cut them, and this one is less well covered. And then you can use Suboxone or buprenorphine naloxone for pain. And again, we tend to use fairly low doses for chronic pain compared to those that we use for opioid use disorder. And there are some rules of thumb that you can find on our website, that we also like talking to people about if you ever have questions about how to go about transitioning patients that you have on chronic opioids for pain, but need a safer or more effective option. What we often see is that we use lower final doses, and sometimes we'll see people decrease that dose over time. Usually we divide it TID, and some insurances will be picky about this if you're not prescribing it for an OUD, but all of this has gotten more simple now. It used to be that you had to prescribe in a certain way with an X waiver for an opioid use disorder, and you had to prescribe a different way without an X waiver for pain. And removal of the X DEA is bringing this prescribing, more in line with other medications and making it easier to navigate. So I think the last thing is a case here. So this is Paul. He's 72 years old. He has post-polio syndrome. He's on CPAP, and he's had a spinal fusion, and he moved from the UP to live with his daughter. And he's been on opioids for a long time for his back pain and post-polio syndrome. And so he takes 10 milligram hydrocodone tablets, 2 pills, TID, and is requesting a dose increase. Oh, and by the way, he's also on benzo. And he's got some disability, and he's got stress because he's living with his daughter who's going through a divorce. And he's done all kinds of other treatment. He's had injections by physical medicine rehabilitation. He's done PT. And so the question is how to handle this. And this is one approach, and this is a kind of common outcome that we actually see, which is, I know it sounds crazy, but I think a lot of us have seen some really, really remarkable improvements for people, which is, we try to not use a lot of opioids and benzos together. It's obviously one of the red flag type things, both in the MAP system, and it's because it does increase people's risk. So in this situation, taper the diazepam, started the buccal buprenorphine, Belbuca, and increased the dose, and it worked. But then, insurance refused to cover it, and this person was switched to low dose Suboxone, so 2 milligrams TID, and now he's able to be more active and doing well without the hydrocodone. Tips for starting this: it's actually much easier than starting for fentanyl or heroin or methadone or any of those long-acting things. Oxycodone, hydrocodone are short-acting, so you just have people stop one day, like at 4 o'clock in the afternoon, not take any more opioids till the morning, and then you start a low dose of Suboxone. If you use the Butrans patch, you can just slap the Butrans on and stop their short-acting opioids in a day or two. And this slide's a bit outdated. You don't have to use your X license anymore. In terms of naltrexone and pain, this one, Dr. Morrow mentioned the importance of knowing who's taking naltrexone, because especially when something terrible happens, like an accident, their opioid receptors are blocked, and it can be really hard to get on top of people's pain. You can overcome it, but it takes a lot. And so you'll see people using lots of large doses of hydromorphone to overcome this. For urgent procedures, you also need to have a plan, and usually it involves a whole team of people, including anesthesia. And for perioperative management, when we can delay elective procedures, we do. If you really can't, then you pretty much know it's going to be a challenge. going in. You can overcome it, but it's not that easy. Oral naltrexone, mostly used for people with alcohol use disorder, is easier because it goes away faster. There are some pain management resources out there, especially this non-narcotic methods of pain management is a good one. And those will all be in the slides that you guys get. There's also some general resources for the course today that includes Michigan Opioid Collaborative, which has a lot of them, and a number of the other good resources that we recommend to people in different situations that has a lot, more than you can explore in any short amount of time. And I'm gonna stop sharing. That was the last slide. Stick a fork in it. This turkey's done. And we'll take a second if anyone has any questions. I'd like to thank all of you for joining us today. We really appreciate it. We know that it's a challenge in lots of parts of the state, but I have to say, we're seeing a lot of change. And so really appreciate all of you participating in that change because, I know John and I both see the same thing, which is, a lot of people are hesitant to treat patients with opioid use disorders. And then, they realize that a lot of the patients that are giving them the most trouble just have an untreated opioid use disorder. And then they start treating it and they're like, oh, actually, this person's like pretty fun and interesting. Like, wow, I should have done this a long time ago. And so thank you all for kind of jumping in. The Michigan Opioid Collaborative is always available for same-day consultations. You can always reach out to your behavioral health person and they can put you in touch with the right people. And if any of you are considering also treating hepatitis C in your patient populations and you're not doing that, make sure you reach out to us because hepatitis C rates are really high in this patient population and it's never been easier to treat. And so we should hop on it before patients develop long-term problems. Dr. Morrow, did you have anything to add before we wrap this puppy up?
Not really. I'll kind of echo your sentiments. Thank everyone for participating. But, yeah.
Well, I want to, from the Michigan Opioid Collaborative, it's Megan again. I have put the PDF in the chat just a few times, but we will be sending that out to you as well today to make sure everyone has that. And we will be sending out the slides as well from your local behavioral health consultant. And again, if you have any further questions or any other ways that the Michigan Opioid Collaborative can help you or your organization, please don't hesitate to reply to our emails and let us know exactly what that means for you. We're very happy to help. I want to thank Dr. Frank and Dr. Morrow too for sharing the information today with us, and to all of you for sticking around and hanging out with us this afternoon. So I'll hang out for a minute just to wrap up some housekeeping items that we have to do here at the end of our Zoom. So if there's anything else, feel free to throw it in the chat or just unmute yourself. Otherwise, I hope you all have a wonderful rest of your Tuesday.